to welcome everyone back. I'd like to welcome everyone back from lunch, and I'd like to start this session. So today I'll be your moderator for this exciting session that's entitled Challenges and Future Directions in CCTGA. I want to just remind everyone to put their questions in the question and answer, and we'll try to get to these at the end of the talks and also at the end when we have a discussion with everyone. So I'm going to introduce our first speaker. We have Alexander van de Brunet, the staff congenital cardiologist at the University Hospital Leuven, Belgium, who has an interest in heart failure related to congenital heart disease and advanced imaging techniques. Of note, they also trained here at the Peter Monk Congenital Cardiac Center for Adults at the hospital, Toronto General. All right.
This is a recorded session, so we're just going to play the movie.
First of all, I would like to thank the organizing committee for inviting me to speak on this exciting symposium, share some of my thoughts. I run the risk of repeating some of the things that have been said in the past 2 days by eminent speakers, but I just want to give my perspective as an ACHD physician on maybe some of the things where we can improve systemic RV physiology and maybe focus on patients with CCTGA. I have no conflicts of interest to declare, and the aims of the lecture are to look at the lifetime trajectory of patients with a systemic right ventricle, CCTGA, to highlight some of the knowns and unknowns in the pathophysiology of circulatory failure for these patients, and maybe some of the future challenges and opportunities for this specific patient group. And let me just start off with a case that Dr. Roche and I have seen in Toronto. And this is a patient, 53 years old, CCTGA, had a 31 millimeter Bjork-Charley tricuspid valve replacement already in 78, and she was doing very, very well. And this is an echo from her 2007 appointment where she was in New York Heart Station Class 1. She had few symptoms. The RV looked stable on echocardiography, and there was no signs of congestion. In 2016, she required an AICD implantation, and she had some fluid overload post AICD. At that moment, she was treated with warfarin and aspirin. She was on diuretics, furosemide, spironolactone, and she was treated with beta blockers and ACE inhibitors that were subsequently stopped because of poor tolerance. And this is the echo of when she came to clinic when I was there with Dr. Roche, and as probably all of you agree, the systemic RV function has come down, and indeed she reported some symptoms, although she didn't have any signs of congestion. Her peak oxygen consumption was somewhat reduced, although her VEV-CO2 slope was fine, and she had significantly elevated BNP levels. And so she was referred for cardiac catheterization, which is standard practice. And indeed, her end-diastolic pressure was slightly elevated, gradient across the valve was fine, and she had pulmonary hypertension with a mean PA pressure of 35, with a cardiac output of 2.7 liters per minute, so a transpulmonary gradient of 15 and a PVR of around 5. And this is more or less the typical patients that you would see in clinic, doing well for a very long period of time. She's 53, but still young, and then having symptoms of heart failure. She ended up having a transplant, if I'm correct. But understanding how the patient comes to this point is very important. And if we look at the lifetime trajectory of the patient with a systemic right ventricle, a patient with CCTGA, it's the perception that these patients do very well for a very long period of time. And indeed, especially if you look at a patient with simple CCTGA who do slightly better than those with complex CCTGA, indeed, they do very, very well for a long period of time. However, when you compare that to what the life expectancy should be, or the Kaplan-Meier should look like, this is the general population, is still a lot worse. So they do well, but survival is definitely worse. And still probably in this study had some survival bias, as I don't think a lot of pediatric patients were included in the study. Still, if you go through literature, there are also some patients with CCTGA who do very well for a very long period of time. And these are some case reports of patients with CCTGA who were older than 70 years during follow-up or incidentally discovered at an older age. So we need to learn from these patients to understand why they did so well for such a long period of time in contrast to others who deteriorate quicker. And so this is obviously true for all of our patients. There's an average lifetime trajectory, but each individual patient is different. And the purpose of us as the aim of us as ACHD physicians is to improve the individual patient health trajectory as much as possible, to improve the health-related quality of life, but also push the limits and actually improve the length of life and improve overall survival. For patients with systemic right ventricle and CCTGA, they have to deal with some things. Starting balance is different. The fact that you have a systemic RV, not a systemic LV, the fact that you have the tricuspid and not the mitral valve in the systemic position, the fact that you have or have not associated lesion will impact this lifetime trajectory. There's factors related to the environment that may play a role, but these are true. These are true for patients in general, for people in the general population as well. And with this start imbalance, there is very specific disease complications that we have to deal or could address better to improve health-related quality of life and to improve survival for our patients. And some of these issues for CCTGA are AV block and dyssynchrony, tricuspid valve disease, and systolic and diastolic systemic RV dysfunction. So let's look at the starting balance. And this has been addressed in the embryology session, I'm sure. But the RV in CCTGA is not necessarily not necessarily the same as a normal RV. It's also not necessarily the same as the RV in patients who underwent Senning and Mustard repairs. So it's important for us to look specifically at the RV in patients with CCTGA. And I'm just referring to this paper of Dr. Huyel from Paris, who looked at the RV and CCTGA and says that the RV inlet and tricuspid valve are always abnormal. There's hypoplasia of the RV sinus, Epstein-like malformation, oftentimes of the tricuspid valve, constriction of the inlet and outlet portion, and abnormal orientation and morphology of the septal band. What I found interesting in this study is that if you compare TGA and CCTGA, you see in TGA, we know that the outflow, that the great vessels and the outflow tract run parallel, suggesting absence of rotation. But in CCTGA, although the great vessels run parallel, the outflow tracts are actually not running parallel. So the ventricular septum in CCTGA is not necessarily straight. Why would that be of interest for me? Because there's always a reason why the ventricle is built that way. If we start on the right side of the slide, there's a reason why the mitral valve is asymptomatic. That the fact that there is a longer anterior mitral leaflet, shorter posterior mitral leaflet, is to create this vortex in the ventricle, which preserves kinetic energy and makes it easier during ventricular contraction to actually push the blood towards the aortic valve. So the nature has a very specific reason for that. If we think about the implantation of mechanical valves, mitral valves in this case, and we have a symmetrical mechanical mitral valve, this vortex is actually disturbed, and we see that there's energy loss just by implanting the valve. Is there a difference in flow dynamics between CCTGA and atrial switch patients? Is this the reason why ventricular function is preserved longer, or should this be a focus when designing mechanical valves in tricuspid position? I think is a very exciting path to discover in the future. We know that there is ventricular independence between the right ventricle and the left ventricle. There's a common septum, there's a shared pericardial space. Septal shift may be of importance, electromechanical dyssynchrony, but there's also shared myofibers and myocardial tracts that run from the epicardium to the endocardium in a right-hand helix fashion. And we know that from diffusion tensor imaging of the hearts is highlighted here on the right side of the right side of the slide. Probably it's not that simple, because this is a similar image, but then in a patient with a failing CCTG, in a failing CCTGA. And if you look at how the myofibers are oriented, this is a normal biventricular circulation with RV hypertrophy. This is patient with CCT. This is patient with CCTGA. If you start by looking at the RV from endo to epicardium, we see that there's a crossing helical arrangement. And you still have that notion here in patient with CCTGA, but it's a bit more disorganized. And you can tell that here on the video as well. Similarly, when you look at the LV and you compare the LV in a normal biventricular circulation to the subpulmonary LV in patient with CCTGA, you see that there's only 2 layers with a circumferential outer layer and a longitudinal inner layer. So completely different. So the fact there will be ventricular interdependence, but it may not necessarily be the same as in a normal biventricular circulation. So we need to learn from that. And this is probably also an exciting way forward. You can use ventricular independence, and it's Professor Reddington and Mark Friedberg in Toronto shown that in a very elegant study where they performed in a pulmonary artery banding model, saw that RV function decreased and collagen content increased to a larger extent in the RV when compared to the LV, but it did increase here as well, although there was only PA banding. But then by increasing the afterflow to the left ventricle, there was improvement in RV systolic function, decrease in collagen content of the RV. So using ventricular independence to treat the patient. Can we transpose this to patients with CCTGA? Maybe we can. This is data from Leuven, where we see that in CCTGA patient with pulmonary outflow tract obstruction, there's less tricuspid valve regurgitation, likely related to the septal shift. But those patients were also less likely to develop systemic right ventricular dysfunction. So maybe a pathway for future studies. Adaptation to increased pressure load will also lead to altered physiology of the right ventricle. And this is again work from Professor Reddington, where he showed that the normal triangular shape of the pressure volume lobe again changes back to a square rectangular pressure volume lobe in the pressure loaded right ventricle, which resembles more the pressure volume load of the left ventricle. And it's only when the right ventricle starts to dilate that the contractility again starts to decrease and cardiac output starts to decrease again. So a dilating right ventricle is probably a bad right ventricle. And again, this is confirmed clinically. This is data from Amsterdam, where they saw that RV anti-systolic volume index in patients with CCTGA was a predictor of adverse outcomes in our patients. So again, confirming that when we understand something well, it translates back to clinic. Adaptation to increased pressure load also means altered cardiac mechanics. We know that for a very long time. Peterson indicated in 2007 already by using deformation imaging that we moved away from the typical RV longitudinal contraction to a more LV to a more LV resembling contraction pattern with less longitudinal and more circumferential deformation. But probably it's not as simple as that. And I just want to highlight this elegant study from the Brompton by Dr. Lee, where they evaluated 3 components of RV contraction, where they evaluated radial motion, anterior-posterior motion, and longitudinal motion, compared that between both transposition complexes, and compare that with healthy controls. Again, CCTGA is not the same as patients post-Senning and Mustard operation. You see an overall decrease in the ejection fraction components and an equal contribution of all 3 to overall systolic function. And it was mostly anterior-posterior motion that related to BNP, which we know is a marker of adverse outcome in patients with CCTGA. So probably just looking at an apical 4-chamber view is not enough when we want to assess systolic function of the systemic RV in patients with CCTGA. This is a busy slide, but it's not. I'm not going into detail, but probably the adaptation to chronic pressure overload is different for the LV and the RV on a molecular level, and a better understanding. And instead of just extrapolating data that we know from the left ventricle and then try to implement this for the right ventricle, the better way forward is to go back to basics, understand what the molecular mechanism is, and find a way to better treat this for systemic right ventricular failure. What I do believe is that fibrosis and stiffness plays a crucial role in systemic RV failure, including for patients with CCTGA. And there's obviously different triggers that may induce fibrosis in the systemic right ventricle, such as mechanical stress and stretch related to increased pressure and volume load, ischemia, inflammation, neurohormonal activations. There are different mediators that may lead up to fibrosis in the right ventricle. And just to show, this is a piece of a systemic right ventricle obtained during RVAD implantation, and the one examining the biopsy actually called me and said, you can just macroscopically see the fibrosis. There is very little myocardium still present in this piece. So just confirming the fact that when patients present with systemic RV dysfunction, heart failure, and need for VAD and transplantation, the systemic RV is probably already very sick, and there's a lot of fibrosis already present. And this is also confirmed by the series from Newcastle, where it looked at their RVAD implantations. And after RVAD, you see no remodeling of the systemic RV. We do see that for the LV. I have never seen that for the right ventricle. Going further on the fact that there's increased stiffness and fibrosis present, this is a sub-analysis of the study I did with Dr. Roche when I was in Toronto, looking at cardiac catheterizations in patients with systemic RV. And this is just the part looking at CCTGA patients, but it just confirms the same thing. There's elevated filling pressures, there's pulmonary hypertension, mostly post-capillary or combined pre- and post-capillary pulmonary hypertension. And it relates to natriuretic peptides and adverse outcome. Of interest is that elevated PA pressures also relate to systemic RV dysfunction, a relationship that was more present or more obvious for CCTGA patients when compared to atrial switch patients. Again, it's not only systolic dysfunction, it's probably a lot of diastolic dysfunction. We have no means of assessing diastolic dysfunction whatsoever. So an important challenge, an important path for future research is further exploration of diastolic dysfunction in patients with systemic right ventricle. It is important. If your filling pressure is high, if pulmonary artery pressure is high, your outcome is worse. The fact that fibrosis is important or is a marker of end-stage failure is maybe not surprising, and it's probably more important to look at the path up to fibrosis, or what is leading to fibrosis. And one of the things that we are examining here in Leuven is the role of inflammation, more specifically the role of neutrophils and activated neutrophils in the development of fibrosis. Here you see early remodeling with some collagen, but less than in late remodeling. And you see, especially in early remodeling, activated neutrophils, less so in late remodeling. That may be a cause for fibrosis. And if we want to intervene in our patients, we should intervene here, because we know, and especially in CCTGA patients, if we intervene too late, it makes little difference on systemic RV function, on adverse outcome. There will be volume load because the tricuspid valve is often abnormal. And opposed to increased afterload. We know that patients with tricuspid regurgitation do worse and do develop systemic RV dysfunction. So important to tackle this early on. If we look back at the Mayo Clinic data, before ejection fraction drops below 40%. But why is this? I'm sorry, this is just going back and forward. Why is this? Probably because combined pressure and volume load in the right ventricle contributes more to fibrosis formation and collagen formation in the RV when compared to the when compared to the LV. Just wanted to highlight this interesting study from the Mayo Clinic. From the Mayo Clinic as well, we know that 50% of our patients will require pacing due to a V block. We know that pacing-induced dyssynchrony could lead to systemic RV dysfunction. But in this large cohort of patients with CCTGA, adjusted for interventions such as tricuspid valve replacement, pacing, and medical therapy, we still see that left atrial dysfunction is common. Maybe not surprising. It's related to tricuspid regurgitation and systolic diastolic ventricular dysfunction. I guess you can see left atrial function as a thermometer for the overall circulation, or specifically the systemic RV. Right atrial dysfunction is also not uncommon and related to adverse outcome. And interestingly, it relates to mitral regurgitation and LV pacing. So putting those pacing leads through the mitral valve, creating some degree of mitral regurgitation may not be as benign as it seems. So novel pacing methods such as leadless pacing may be of interest also in patients with CCTGA. Subpulmonary LV dysfunction is related to subaortic RV dysfunction, again, an indicator of ventricular interaction. And what was interesting for me as well is that RV dysfunction was related to LV pacing. Not surprising, we would go for CRT or left bundle branch area pacing if possible, but also to arterial hypertension, indicating the sensitivity to increased afterload of the systemic right ventricle. So we should treat arterial hypertension when present. So all of these things together cause systemic RV, but biventricular dysfunction. So there's adaptation to increased pressure load or additional pressure load in the setting of arterial hypertension. There's volume load in the setting of tricuspid regurgitation, but do not forget mitral valve regurgitation. The interventions that we need to do, the tricuspid valve replacement, pacing, pacing-induced dyssynchrony and ischemia, all of these things define biventricular morphology and function. And especially in CCTGA, we probably want to intervene early on, because we know if we don't, heart failure, systemic RV dysfunction will be common. And this is just data from Leuven indicating that over half of patients older than 50 years of age will have heart failure in case of a biventricular circulation with a systemic RV. So, ladies and gentlemen, to conclude, long-term outcome in CCTGA is impaired and relates to differences in anatomy and physiology, adaptation to different and changing loading conditions, insights in the specifics of CCTGA anatomy and physiology creates definitely opportunities for improvement, asymmetrical mechanical valves, pulmonary artery banding. Timing is everything in CCTGA. Once there is systemic RV dysfunction, once there is overt clinical heart failure, interventions such as tricuspid valve regurgitation, CRT pacing, medical therapy have little proven effect. We have to realize that targets for treatment may differ from the LV, and we need to invest in better insights into the mechanisms leading up to fibrosis and dysfunction. And maybe inflammation is one of the pathways, but there may be many others. And even small bits count in CCTGA. So we should address hypertension, address volume load early on, pacing, avoid pacing-induced dyssynchrony and go immediately for LBB area pacing or CRT. We should assess all chambers. We should look at the left atrium because it's the thermometer of the systemic RV. We should assess mitral valve regurgitation, avoid pacing leads if possible, and look at subpulmonary LV and RA dysfunction. Thank you for your attention.
All right, thank you very much for that very interesting talk. I don't know if Alexander's online to be able to answer some questions.
I am, Rachel.
Yeah, perfect. Okay, great. I guess just while we're waiting for things to come into the question and answer, I was very much struck with the idea that you presented about trying to actually understand how the systemic RV is different based on all the different parameters, as opposed to us applying what we know from sort of our normal concordant arrangement. So, where looking at EF and BMP may not be true markers of when the tipping point is for a systemic RV. And I was wondering how you think we can go about achieving that. I think, numbers are small in each individual center. So how do we sort of try to get a lexicon of sort of comprehensive physiological imaging, as well as, do you think that there's a role at all for biomarkers, in conjunction with looking at the imaging that you could potentially obtain?
Thanks, Rachel. That's an excellent question and a very difficult one to tackle. I guess the point is by just beginning to understand that it's not just transplanting the IDs we get from acquired heart failure from the LV and transplanting them to the RV. That's the beginning. Second, I think that we, even knowing that the systemic RV in atrial switch patients, which I still see, probably my pediatric colleagues don't see them anymore, but it's not the same as a CCTGA. So probably in some of these patients, the valve and the ventricle and the conduction system actually works pretty well. And maybe if we do diffusion tensor imaging, if we do blood speckle imaging, if we do high frame rate imaging in those patients, we start to understand why these patients do better than the ones that are actually failing earlier on. When I went through the talk, and it was a difficult, I must say, it was a difficult one, because after all the speakers who have spoken the past few days, saying something new was not necessarily an easy task. But I do think, just with my small clinical experience and the data that is out there, I think that for an RV, when the RV starts to fail, you're too late. And that's probably why medical therapy doesn't work, why any intervention that you do doesn't work. It's proven every single time. Tricuspid valve replacement, you should do it early. If you do CRT after there's RV dysfunction, it doesn't work. So we should intervene earlier on, and the RV is probably more fragile than the LV. And then with regards to biomarkers, I do think biomarkers are actually pretty useful. When you look in clinic and you look at the RV and of this older patient, it always looks a bit funky. It's never normal. If you can compare, like the case I showed, sometimes it's obvious, but it's not always that obvious. Biomarkers help me. Referral for cardiac catheterization helps me. And I think in Leuven here, we're exploring a technique that is called high frame rate imaging. And I know Luc Mertens is exploring that as well in Toronto. I think that may be an exciting avenue to actually better understand stiffness and filling pressures in systemic right ventricles as well. If you meet him, just tell him that he should do it, because you have the patience and you can provide the data.
Oh, you're muted, Rachel.
You're muted.
Sorry, we have a couple of questions here in the actual Q&A. So based on your discussion, shall we treat the systemic RV very early, even before any symptoms or before dysfunction develops? And I think you kind of alluded a bit to that.
So yeah, I've thought about that. The problem is that what will you treat them with, right? You'll treat them probably with classic heart failure therapy, and that is data that you got from left-sided heart failure. So no, for the moment I don't. But if I understand, or if you give me a reason from basic science that I may consider it. But you can't just extrapolate from acquired heart failure.
Great. And then our second one, do you think that heart failure medications may help the left ventricle, and the left ventricle may then help the right ventricle? Very much getting into interdependence.
Excellent question, Marcus. That's when I see LV failure in a patient with CCTGA or systemic right ventricle, it's usually very late in the disease process, and I don't think that at that point, I think what Dr. Roche said is that you should actually assess for advanced heart failure therapies and that the patient is going down quite quickly. Having said that, there's some data out there that when you have pulmonary outflow tract obstruction, that actually creates some opportunities, maybe avoiding tricuspid regurgitation and systemic RV dysfunction on the long run. If you have LV dysfunctions, probably biventricular dysfunction at that point, I don't think medical therapy will help, but that's just a personal opinion. There's no real data.
Okay, great. Thank you. I'm sure we might have some time for everybody to have some discussion at the end of the session, but we'll move on to our next presenter. So our next presenter is Miriam Alamar. She graduated from King Faisal University in Saudi Arabia and completed her cardiac surgery residency program here at the University of Toronto. And currently is a congenital clinical fellow here at the Hospital for Sick Children. So today she's going to talk to us about Toronto CCTGA outcomes.
Thank you very much, Dr. Van der Laan, for the nice introduction. It's an absolute pleasure to be here with you all and to present the Toronto CCTGA experience. I'm just going to share my screen. I have no conflict of interest to disclose. First, a slide, this shows the trend of surgical repair over the time. Gray represent physiologic repair, blue represent anatomic repair. And as we expect, we found significant trend toward performing more anatomic repair over time. Over 34 years, from 1982 to 2015, we have 165 patients with biventricular CCTGA. Groups where physiologic repair, anatomic repair, no intervention, patient required no intervention, and to understand and to gain perspective on the Fontan outcomes, a left-hand topology Fontan patient were reviewed. There were a total of 35 patients. 8 patients were found to be balanced ventricle, 3 had balance with straddling AV valve, and 5 had absent of AV connection with large VSD. The other 27 were pure single ventricle, dominant RV with pulpoventricular outlets. This slide, it shows the definition of each group in our papers summarized in this table. First, a group physiologic repair where correction of the intracardiac lesion was performed with VSD pulmonary stenosis, however, leaving the morphological right ventricle to support systemic circulation. Anatomic repair is performed by restoring the morphological LV to systemic circulation by mean of arterial atrial switch or Rastelli, Rev, Mikaido, and atrial switch. Single ventricle group are those patients who had their Fontan procedure completed. We had also looked at those patients who had no intervention, and their patients are either isolated CCTGA, meaning they have no VSD or pulmonary outflow tract obstruction. However, they may have other patient included may have an extracardiac lesion like PDA, coarctation, or pacemaker implantation. We had also a good number of patients who had shunt like PA band, BCPS, or single ventricle pathway awaiting definitive repair. Those patients, we looked at them. However, there was no specific statistical analysis was performed to those patients or this group. This figure summarizes the number of patients in each group. The majority, as we can see, were found in physiologic repair with a total of 89, and the smallest number was found in a single ventricle, however, relatively similar to the other anatomic no intervention group with 38, 35, and 38 patients. Out of the anatomic group, we had 19 underwent double switch operation, 15 had Rastelli, 3 had Rev, and only one patient had Nikaido. The median follow-up was significantly different between the groups, and as we expect, the longest follow-up was found 13.5 years in physiologic repair, and shortest follow-up was only 3.4 years in anatomic repair group. In terms for the median age, we found the median age was 5 years in physiologic repair, 3 years in anatomic repair, and 4 years in Fontan group. We did also look at the median age for the specific group in anatomic repair. Those who underwent double switch had 2.3 years median age, and those who had Rastelli, it was 3.6 years. In terms of transplant-free survival for the entire cohort from 1980 to 2015, we found no significant difference between the group in terms of transplant-free survival. However, an anatomic repair had the lowest transplant-free survival, which was 53% at 20 years. That compared to 65% in the physiologic repair and 73% in the Fontan group. We looked specifically into the last era, which is patients who had their index operation after 2000. And for their result, it actually was similar. The lowest survival was noticed in anatomic repair group, with transplant-free survival at 10 years was 79% in anatomic repair, 86% in physiologic repair, and 100% in the Fontan group. This is slide, it represents or shows the transplant-free survival for those patients who required no intervention for their VSD or pulmonary outflow tract. But again, to remind the audience, those patients who also may have an extra cardiac repair than like coarctation, PDA, or pacemaker implantation. And as we can see, they have excellent survival with 25-year survivals reaching 94%. We looked specifically into analysis into the multivariate analysis for survival. We found none of the surgical group found to be a significant predictor for late mortality. However, index year after 2000 was approaching to be a protective factor, and having moderate to severely reduced ventricular dysfunction shortly after the index operation was approaching to be a predictor of late mortality. This table shows a multivariate analysis for the systemic ventricular function, and we found that last era, which is patient who had their operation after year 2000, was protective. However, moderate or having moderate to severe systemic ventricular dysfunction was found to be a predictor of late systemic ventricular dysfunction. If interesting, age at index operation was not found to be a predictor. And this is the multivariate analysis again for looking at the systemic AV valve function. We found both Fontan procedure and index year after 2000 to be a protective, with odds ratio as 0.1, p-value 0.02, and for the Fontan and for the index operation after 2000 with p-value 0.03. However, having moderate to severe AV valve regurgitation shortly after the index operation is found to be a significant predictor for late systemic AV valve dysfunction with a p-value 0.01. Echo data were collected to compare the systemic AV valve function and systemic ventricular function before the index operation, as we can see in the top panel, and compare it to shortly after the index operation and in the last follow-up. As we can see here in the anatomic repair group, 19% underwent their repair with moderate or had moderate to severe AV valve dysfunction before the repair. It was less shortly after the index operation. However, it got worsened with almost reaching 20% in the last follow-up. With regard to the physiologic repair, they had less systemic AV valve regurgitation before the index operation. However, not surprisingly, almost 50%, 46% of those had a significant AV valve regurgitation at the last follow-up. This was not a significant issue for the patient who had Fontan and those who had no intervention group. With regard to the systemic ventricular function, this figure again shows the status of the systemic ventricular function again prior to the index operation, shortly after the index operation at the last follow-up. And as we can see here and notice, almost all patients in all the group had normal or mildly reduced systemic ventricular dysfunction before the index operation. However, shortly after the definitive repair, we found moderate to severe ventricular dysfunction became more prominent in the anatomic repair group compared to physiologic repair or single ventricular group. And even more noticeable in the last follow-up, with up to 20% of the anatomic repair had moderate to severe systemic ventricular dysfunction, with a median follow-up of 3.4 years. We were of a serious concern with regard to the late systemic ventricular dysfunction in the anatomic group. And so we looked into to see, to better understand it, we'll look at those unfortunate 20% who had worse outcomes. And there were 2 underwent double switch. 6 of them had Rastelli. Only 1 patient of the double switch had a PA band before the procedure, and it happens twice at the age of 8 years old, and then at a year later at 9 years old before he underwent the double switch at the age of 11. The median age for these patients who had worse outcomes was 6.8 years in double switch compared to 4.2 in Rastelli, compared to 1.7 versus 2.9 years respectively in those patients who had normal morphological systemic ventricular function at the last follow-up. But again, to remind, in a multivariate analysis, we found age was not a predictor of mortality in our late LV dysfunction. In summary, in this cohort, a survival advantage of anatomic repair for CCTGA was not identified. In the most recent 15 years, systemic ventricular function and survival were similar between anatomic and physiologic repair. However, we notice a general decline in systemic ventricular function and issues with systemic AV valve in almost all the groups. Midterm Fontan survival was relatively favorable. Pushing the borderline repair may not be necessary. Those without intracardiac lesion requiring repair had the highest survival of 94% in 25 years, raising the questions, should all CCTGA patients undergo anatomic repair? Thank you for your time, and I'm ready if you guys have any questions.
Hi, thanks. So I'll just open up the Q&A for anyone who might have questions. I guess the first question I might sort of talk about is, with the adoption of any new type of repair, there's always a learning curve as you acquire expertise. And would you anticipate that with a focused group and sort of examining your previous outcomes, that you might see that with better patient selection or understanding who would best benefit, as well as, with, surgical expertise, that you may find, well, like what some groups have found, is that the anatomical repair can be similar in terms of its outcomes?
Yeah, thank you very much for this nice question. It's actually, that was something that we had actually looked into it, and we specifically looked into the patient who had their index operation after 2000, as we expect that the outcome will be better with the most recent years, and that was actually prominent. However, we didn't find a significant difference comparing anatomic to physiologic repair in the most recent era. but it definitely shows better outcomes compared to those patients who had anatomic repair in early 90s.
Great, thanks. I think David Barron has a question.
Thanks. Just to make sure to clarify, to make it clear to the audience, amongst those who had a physiological repair, what was the incidence of significant AV valve regurgitation at their follow-up?
At the last for those who had physiological repair, at the last follow-up, we had almost 48% had significant AV valve regurgitation.
I think that's one thing just to be aware of, isn't it? To highlight is that the physiological repair still, which is most people's experience, that so you've got half of the patients who've got significant AV valve regurgitation. And I think also the Fontan group, also we have to be careful how we compare them, because the Fontan group are really on the whole, they're a single ventricle group where there's no question of being able to offer any sort of biventricular repair. Many of them only had a single AV valve. So to compare the outcomes, again, we have to be a bit cautious how we compare things. I think it is interesting that sometimes the Fontan has been used for patients with two good ventricles, but with a remote VSD, where difficult to perform a sort of Rastelli type repair. And those, I think, are valid to compare to the biventricular repairs. But in this sort of particular study, the Fontans aren't really ever candidates for biventricular repair. So I think it's just to bear that in mind.
Thank you very much. Yeah, it's absolutely valid.
Okay, and we just have two questions. So one was just asking about, were there differences in quality of life or functional capacity between the Fontan and the anatomical repair groups? I don't know if you had a chance to look at that.
Yeah, unfortunately, this is a very good question. However, we didn't look into the exercise test in those patients, although it was something that we had in mind, but just for the sake of the paper, we did not look into this. And then
the last question is, did you stratify patients who underwent the double switch by age? Are any of these patients without LV dysfunction, even though they had banding for LV training?
Yeah, that's also a very excellent question. We had a very few patients who had a Bay band in our cohort, and those patients, only patients who presented with morphological right ventricular dysfunction or more than moderate TR, who were considered to have a Bay band. Otherwise, prophylactic Bay banding and double switch was not usual practice in our center.
Great, thanks. For the sake of time, we're going to move on to our last speaker. So I'd like to just introduce Osami Hanjo, who is one of our staff cardiovascular surgeons here at the Hospital for Sick Children, and he's an associate professor at the University of Toronto. He's the surgical director of our heart transplantation and mechanical circulatory support, and is also a senior associate scientist in the translational medicine at our research institute. He specializes in neonatal and complex cardiac congenital surgeries, and also surgeries for the mechanical support. He is also very active in our adult congenital heart disease program here at Toronto General Hospital.
Thank you very much for the introduction, Rachel. Can you see my screen?
Yes, we can see your screen.
Okay, perfect. So thank you, and welcome everyone for the Toronto Symposium. Hopefully you're having really good sessions yesterday and today. My topic is about the role of surgery in the CCTGA cohort in the adult congenital program. Hopefully this is a nice sort of a follow-up the talk after Mariam's excellent overview of children who have corrective surgeries. So the patient, as you saw in the very last talk by Mariam, this patient with CCTGA who received various type of treatment in childhood have a sort of a resulting in heterogeneous subgroups, really depending on what type of initial intervention they get, either anatomic or physiologic, or some cases unrepaired anatomy. So just kind of group those patients as an adult. The first group is the patient who never have a major surgical intervention. So they tend to have an intact ventricular septum or physiologically unimportant ventricular septal defect. They may have various degree of systemic tricuspid regurgitation and various degree of ventricular dysfunction and subpulmonary LVOT gradient. And then those patients may or may not need a surgical attention as an adult patient, but that's one sort of a population that we deal with. The second patient is a kind of interesting population who had palliated with PA banding. The PA banding can be applied as a childhood to adolescents when they have systemic right ventricular dysfunction or progressive tricuspid regurgitation, or maybe the initial intention was to retrain the left ventricle, but some patients end up not having definitive biventricular repair, and then have a PA banded state. And the third group is post-physiologic repair in the form of BSD closure, plus minus LV, subpulmonary LV to pulmonary artery conduit. So they obviously they have a systemic RV in the they have a various ventricular function, and then various degree of systemic tricuspid regurgitation. And then obviously they tend to have a conduit from morphological LV to PA with various degree of obstruction and regurgitation. And then the last group, which we will see more in the future in the adult congenital program, is the post-anatomic repair patient. As Mariam showed in the last presentation, we are doing way more anatomic repair in the form of true double stitch or Rastay plus sending a mustard in the recent 2 decades. So those patients will come to the adult program as a growing population. So they have a morphological left ventricle as a systemic ventricle, but obviously what we are learning that there's some patients have significant morphological left ventricular dysfunction. So they have their own set of problems, such as conduit obstruction or regurgitation if they have a Rastay type operation, and then baffle status. They have a venous baffle, and then if you have a Rastay, you have an intraventricular baffle as well. If you have a true double switch operation, BTJ who have a arterial switch operation, we have to care about coronary artery patency in the long term, and then the last with the neoatic valve insufficiency. So those are the kind of 4 main group that we had to pay attention to as an adult congenital program. So the role of ACT surgery in a CCTGA for the adult patient is really to try to maintain systemic ventricular function, whatever it is. For now, we are mainly dealing with systemic RV function, but when the patient who have an anatomic repair comes to the adult age, we have a new set of challenges to maintain those morphological LV function. So and then intervene hemodynamic conditions such as AV valves, semilunar valves, conduit, baffle in a timely manner. Based on Alex's talk, which was quite important in a way that the timing of intervention is crucial in this patient. And then the third point is that utilization of PA banding is quite interesting, and I think still evolving in some sense. And this is used as a retraining purpose in the children, but not so much for the young adult anymore, but bridge to decision or repair or transplant or the destination therapy. And I'm not going to go through a lot on the ventricular assist device transplant role, as Dr. Roche already discussed it in detail, but that's a part of what we do as a surgical group for this patient with CCTGA in adults. So this is the overview of surgical reintervention. So this is one of the biggest surgical cohort from Tokyo Women's University, spanning 3 decades plus, close to 200 surgical patients. And then the median age is 80 years old, but spanning from 2 months of age to 47 years of age. And so what I'm trying to show is kind of, so this is the overview of what they had. So about 1/3 of the patients have a physiologic repair in the form of either conventional VSD closure or conventional rasteri with LV to be a conduit. And then about half of the patients have a sort of double switch operation, either the true double switch with the arterial switch and then the HO switch, or more commonly rasteri plus HO switch. That's about 1/3, and then about 1/5 of the patient have a single ventricle palliation. And then just focus on the reoperation rate. It's interestingly, so this is I would say universal for any large disease, but if you compare the conventional and anatomic repair, the reoperation rate is quite similar. And then the freedom from reoperation stratified by the systemic ventricle, it's essentially identical. So when you have a physiologic repair, they tend to have more systemic tricuspid valve intervention, not surprisingly, and then the conduit exchange. And then when you have anatomic repair, either the true double switch or rasteri plus HO switch, they have systemic autotract reoperation, closing the residual shunt, and then baffle obstruction, and so on. And another important message from this study, which is very similar to what Mariam just discussed. So the probability of survival is really very similar among all groups. In other words, there's no true benefit of anatomic repair in this cohort, although this cohort is relatively old, from 1970 to mid-2000. And then morphologic LV versus RV for the systemic ventricle, there's no difference in this particular cohort. Obviously, this result is probably evolving as we have more sophisticated surgical techniques, we have better myocardial protection and so on. So this may change in the future with a more contemporary cohort, but and then the other things, this will be a common theme in my talk. So if you have a systemic tricuspid valve regurgitation, they have much worse outcome. So just summarize. So this is just an overview of what we have done in the Toronto program. Dr. Kobayashi is a research fellow in sick kids. He kindly summarized our experience in the last 4 decades. This includes all the patients who have treated surgery in the Toronto Adult Congenital Program from 1976. And then that's a little more than 100 patients. And then this is greater than 18 years of age. So intact ventricular septum count for about half, and then the other patient with a CCTGA VST with some degree of pulmonary obstruction. So this is the kind of breakdown of what they had as a surgical intervention. About half of the patients have some either the primary physiological repair or some reintervention after physiological repair. So the most commonly systemic Tricuspid replacement, then LVPA conduit exchange, and some patients have a Fontan procedure as an adult. The 2 patients have a double switch operation, and recent cohort of the 10 patients have some form of destination therapy, such as ventricular assist device implantation, both as a bridge to decision, and then 8 patients have a heart transplantation. So I didn't have a good place to put this thing, but when you have a physiological repair, it is important to note that we try to undersize this LVPA conduit so that will act as a sort of a partial band physiology, so that we keep the ventricular septum sort of stented. For the same reason that we have higher threshold to replace stenotic LV2PA conduit, because that's somewhat protective to the systemic right ventricle in the physiological repair. And then, so this is a breakdown. The top panel is an intervention we've done for the patient before 2005, so it's kind of an old era, and then the 80s and 90s, and then this is a more common era in the lower panel. So you can imagine, so the top panel, the majority of patients have a physiological repair, and more recently we have a variety of patients. So the physiological repair or maintenance surgery for physiological repair is still the most common one, but you can imagine we have more patients who need a transplantation or ventricular assist device, and then many patients actually have a pulmonary artery banding for various reasons. Some patients got it for LV retraining for late double switch, and then some patients for sort of other treatment for progressive right ventricular dysfunction. So among all cohorts, the hospital mortality is about 5%, then 11 patients died in the follow-up period. So this timing of systemic Tricuspid valve replacement, as we learn, the timing for intervening this regurgitant systemic Tricuspid valve is really important. This is, let's say, one of the biggest series from Mayo Clinic to look at the 19 patients who have severe Tricuspid valve regurgitation with preserved systemic ejection fraction greater than 40%, and that's compared to the 27 patient who have reduced systemic RV function less than 40% ejection fraction. And so you can see this up to 5 years, it doesn't really change much, but towards the 10-year mark, there's a statistically significant difference in terms of survival if you compare to the preserved functional group. And the other thing is this: they compare the patient who have elevated subpulmonic LV pressure or elevated pulmonary artery pressure prior to tragus valve intervention, and then clearly the patient who have elevated PA pressure or have a secondary pulmonary hypertension do worse after the tragus valve intervention. So that's really speaks to the importance of timing of tragus valve intervention. So the other population that I want to talk about is this patient who never had a surgery before and then came to the adult congenital program and then had some form of surgery. As you learn from a sick kids experience, the first 20 years, their survival is excellent, so close to 95% survival among the patients who never needed surgery. And then, so this is the cohort. So that consists of 53 patients. So this does not include a patient who, again, never needed surgery as an adult congenital program. So this is purely the patient who needed the first intervention in the adult program. So this is a breakdown. So majority of patients underwent some form of physiological repair. Either the isolated tragus valve replacement plus minus VSD closure. The patient got Fontan, which is amazing. So the one patient got primary heart and lung transplant. Assume this patient probably developed a significant pulmonary hypertension during the follow-up. And then 2 patients got a double suture operation and 1 survivor. And then 4 patients have a pulmonary artery banding as a decision or destination. So before 2000, majority of the patients have a physiological repair. And then after 2000, the more patients got PA banding, and then some patients got Fontan operation. So hospital mortality is 6%, and then 6 another late death. So again, Mayo Clinic data, very similar group. So just note that this paper is relatively old, so published in 2002, so it doesn't reflect the contemporary group. But the patient, so 44 patients who unoperated CCTGA as an adult congenital program, and then 30 patients required surgical intervention, and then all survived the surgical intervention, and then 1 sort of non-cardiac death at the follow-up. So if you look at the breakdown of the procedures, so all 30 patients needed, or the patient who need a surgical intervention, that means they need a replacement for systemic tragus valve, and then the various other interventions like VSD closure, and then aortic valve replacement. So this is obviously there's no surprise to see reducing ejection fraction after a systemic tragus valve is replaced, but the mean ejection fraction prior to that is 40%, and it came down to 34% mean. So they're certainly a vulnerable group moving forward after the tragus valve is replaced and have a competent valve. In addition, the 4 patients, so about more than 10%, need a heart transplantation. So it is hard to find the sort of long-term outcome of PA banding as a definitive palliation or destination therapy. I don't think we have good data exist in the literature. Certainly, we don't have a lot of patients. So this is Dr. Barron's and team from Birmingham's. I think this is probably the best paper to kind of get the sense of what's going to happen to those patients. I'm mainly looking at this patient who have a post-mastoidal setting, who have a systemic RV dysfunction and need a palliative banding. Because this CCTGA group is relatively young when you have a banding, so probably it's not a good group to consider as an adult congenital population. But when you have the PA banding as a palliative procedure, 10-year survival is about 70%. So it sounds it's acceptable or reasonable to subsequent transplant. So we have a total of 7 patients who have PA banding as an adult. And there's an era that Dr. Reddington and Dr. Van Asser was running the program to be more aggressive in terms of retraining the morphological left ventricle for the late double switch operation. And the one patient have a true double switch operation. This patient survived. And then among 7 patients, 2 patients developed RV dysfunction, so they switched to physiological repair, and 5 patients still have PA band as a sort of destination. So just to finish off, so we are bridging to transplantation, and then whether or not transplantation is a ultimate goal. Certainly, we are doing more transplant in a recent year for the adult congenital population. But if you look at this Kaplan-Meier curve, it's not perfect. If you look at the 5-year survival of adult congenital transplant, it's about 80%. So yes, it is a good ultimate rescue, but it is not a perfect solution. So whatever we can to preserve the systemic ventricular function and manage medically, that might be a goal. So just to summarize, there are several types of the patient cohort or subgroup that we had to deal with. The majority of current patients are post-physiological repair, but we expect to have more patients with anatomic repair in the form of true double switch or RAS-A plus HS switch in the coming years. And then they have a whole set of problems like a baffle, coronaries, narrow aortic valve, but might be a new set of problem coming up. So timing surgical intervention is important, particularly the timing of systemic tricuspid valve replacement in order to save the right ventricular function. So PA banding is a valuable option for bridge to decision or other destination, or for the ultimate potential transplantation. But as you can see, that not all patients can tolerate this afterload, particularly when you place the band as an adult, and then you may have to deband it. The transplantation is reasonable, but not perfect. I think emphasize the 5-year survival is 80%, but it is ultimate rescue option for this specific subgroup, and therefore, if you consider this as ultimate rescue, we have to be very considerate how many sternotomy we can afford. Obviously, less is better, so we have to combine medical, surgical, interventional therapy to sort of minimize the sternotomy before transplantation. And then also we have to monitor the development of pulmonary hypertension. So if they have established pulmonary hypertension, they may not be a candidate for transplantation. Thank you for attention.
Great, thank you for that excellent talk. I'm just mindful of the time and that we have about a couple of minutes left. So if you have any questions, to please put them in the Q&A, And I'll just address one that was just put. So in CCTGA, intact septum LVOTO, what degree of PS is acceptable and doesn't need intervention?
I'll say, I mean, we just go by the like a regular criteria of conduit stenosis, right? So, you know, let's say you have a less than 2/3 or even less than 70% systemic LV pressure, subpulmonary LV pressure with good LV function. I think that's really good, you know, natural palliation. I wouldn't touch that. If you have a subsystemic subpulmonary LV pressure and or deteriorating LV function, then we have to do something. I think it's very close to the criteria to intervene LV PA conduit after physiological repair. I think we are very conservative, meaning I think that's somewhat protective to the systemic RV function and geometry in a septal position. So I think we accept sort of at least 70% systemic.
Great. And did anybody else have any questions from our panelists before we wrap up?
It's David here. Can I ask one thing? Because I'm intrigued. So I don't think any of us know the answer. But what do you think, Asami, about this idea that if you have an adult where you intervene with a tricuspid valve replacement, usually for TR, should we be putting a band on at the same time to somehow support the ventricular septum, or does it not really matter once we've replaced the valve?
Well, I'm personally a big fan of PA banding in this context. I mean, it's really doesn't it doesn't hurt as long as band is not too tight, and then it certainly helps to keep this the location or a position of the septum in the middle. So I learned one of the recent patients who are on ECMO after physiological repair, and then we pressed the band when we came off of ECMO, and certainly with a band, the ventricular septum is in a better position. If you think about the ventricular dilatation as a first sort of a trigger to cause this systemic RV dysfunction, it does make sense to put a looser band, particularly in adults, because the band won't get tighter because they don't grow into it.
Yeah,
that might be a good option to consider.
Okay, great. So I think that concludes our session today. I want to thank everyone for their excellent talks and all the great participation from the audience, and I'll turn it over to our next session.
Excellent. Thank you so much. It's been really a wonderful day, and super excited to move into our next session here. And maybe we'll start off by just allowing everyone to on the panel to introduce themselves. I am Elizabeth Stevenson. I'm the section head for electrophysiology at SickKids, and I'll pass it on to Michael Alice.
Hi, I'm Michael Alice Melga, and I'm one of the cardiac intensivists at SickKids.
And I'm following right after. I'm Christoph Haller. I'm one of the cardiac surgeons here at SickKids.
Excellent. That's great. I think that's it for our staff participants. And so we can move into our program. Michael Alice, do you want to introduce the first speaker?
Absolutely, I can. So our first case presenter And I'm going to apologize ahead of time if I mispronounce your name. It's Boo, and your last name is difficult. Would you like to pronounce your last name for me?
Okay, my full name is Bohren Karastiko.
Thank you. You said it way better than I would have, and we're very excited for you to present our first case for us.
Thank you. I'm going to share my screen. Just give me a while. Okay, I hope you guys can. Okay, my name is Bo. You can call me Bo. I'm one of the Pediatric Cardiology Echocardiography Fellow here in SickKids. Thank you so much for having me here to present this case actually. So what we have here, the first case is that the data was a bit scanty. So this whatever data that I have is that this case was, the patient was referred to us at the very early on at 27 weeks for suspected congenital heart disease to SickKids for fetal cardiology. So the echocardiograph, the fetal cardiography, what you can see here is that, okay, before that we have to orientate ourselves. So this is the right side, this is the left side, this is anterior, there's your posterior. So what you can see here is that the apex of the ventricle is actually pointed towards the right side. So this is the dextrocardia and the position is a bit mesocardic. So and then you can see here the right-sided ventricle. In terms of morphologically, it looks like morphologically left ventricle because it is smooth, and then it's not very clear, but actually the right ventricle actually you can see a bit of offsetting of the valve, and as you can see actually there's a bit of moderated bend there. So basically this is the right ventricle. The left ventricle is actually on the right side, and the left ventricle is on the right ventricle is on the right side. And then the thing that I didn't show to you guys actually is the position of the IVC and the aorta. It is a cytosolitis, except the aorta is slightly to the mid portion. And then the IVC did drain into the right atrium. So at the same time, from here, you can see that initially it was thought that the pulmonary vein drained into the right-sided atrium. So at this juncture, so that's why it was thought with all these parameters, they thought there's a possibility of right isomeric at this juncture. And then in terms of looking at the great arteries, you can see there's one great arteries coming from the left-sided ventricle, which is the right ventricle. And then I'm so sorry for the choppy videos. Okay, from here you can see, again, this is a better view looking at the pulmonary arteries. So you can see as we sweep further, you can see that's part of the RPA, LPA. However, there is no connection from the ventricle to the base. Basically, there is an element of pulmonary atresia. And then with this color, you can see that the PA branches are confluence, and there is a reversal flow, retrograde flow from the PDA, which most probably at this time we thought it arises from the coming from the left nominate artery. On top of that, patient does have right-sided arch. Otherwise, the arch looks normal, and you can't see nicely the PDA because it's a bit vertical. So the primary diagnosis at time when patient was diagnosed during this juncture was patient to have a possibility of right isomerism, right cardiac mesoposition, CCTGA pulmonary atresia with large VSD, and also TPVD, mostly drained to the right side of the atrium with bilateral SVC. So in view of this element, so the parents were informed that the prognosis was guarded, and then however parents requested to continue with the pregnancy. So patient was delivered, I'm not entirely sure how patient was delivered, but it was not eventful. And then what you can see from here, this is the first postnatal echo. So what you can see actually is that the IVC actually is on the right, the IVC is on the right side, and then the aorta actually is more the mid portion, and as it rise up actually is both actually on the right side. And then we can see here when we trace the IVC, all the been to the IVC and it drain into the right side of the atrium. And then as we furthermore can see actually it is a dextrocardia. Okay, so from this view you can see there's a lot of things you can see from here. So first of all, you can see actually in terms of pulmonary vein, the pulmonary actually does because there is a huge ESD there. So actually all the pulmonary drain to the left side of the atrium. And then you can see here actually, you can even see the attachment of the chordae. So basically, this is part of the right-sided ventricle. The right-sided ventricle actually is the left ventricle. because and then this part, the left side really is the right-sided ventricle. And as we sweep it anteriorly, you can see there's a large VSD, and the aorta is coming out from the left-sided ventricle, which is the left-sided ventricle, which is the right ventricle. And then from this non-sweep video, you can see actually there's a huge VSD, and then you can already see that actually there is no issue with committing from the LV to AO. And then there's another view to see on parasternal axis. You can see there's a large VSD, and then there is a quite laminar flow from the LV to VSD to the AO, and then there's no issue with the aortic valve. There was hardly any AI. And then you can see actually both PA branches are confluent, and then there's a bit of pinching at the proximal LPA where the insertion of the PDA. At the same time, I forgot to mention is that you can see the typical position of the aorta and also the PA, where the aorta actually anterior leftward. And then from this view, you can see the coronary arteries, the usual CCTGA coronary arteries, where the left side, the right side is actually giving rise to LAD and LSIP from the LC evacuation. And then you can see the aorta is coming from the left-sided ventricle. And then from this view, you can see nicely is a single right SVC, and then there is a large PDA coming from the left innominate artery draining into the PA branches. And then both pulmonary veins are drained into one confluence, and as I mentioned before, it drained into the left-sided atrium. So at this juncture, it was diagnosed as a CTGA, pulmonary atresia, large VSD with unobstructed subpulmonary or subaortic area and unlikely to be heterotaxy. So now comes with the first question, would be what would be your initial management? It is quite interesting because I would definitely think there'll be the management is a bit different at this juncture depending on center to center. So maybe what you can do is that you can do the usual thing, do the poll, and then we will see how many of you guys will choose either PDA or BT shunt. So maybe someone can show the poll.
Just a reminder, there's a link in the chat as well.
Oh. Okay, let me just give a few seconds. Okay, so definitely you can see actually from here, most actually said would prefer PDA stenting over BT shunt. So so how do I share back? Okay, where is? Okay, for this answer, it depends, I guess. Yes, I mean, in terms of what is with the current new trend, I guess PDA stenting would be the main of choice because there's lots of studies. This one a study that actually I choose. It shows that in terms of the endpoint death or unplanned admission, there is not much of difference. However, in terms of morbidity, in terms of pulmonary artery size, it favors PDA stenting compared to BT shunt because usually in BT shunt, the ICU stay will be longer compared to PDA stent. But however, I guess it depends on center to center. If the center has a preferable to do BT shunt, like in my center in Malaysia, sometimes we do lots of BT shunt sometimes instead of PDA stenting because it also depends on how bad is the PDA itself, the morphology of PDA. So and then it also depends on the resources of the center. So I guess it would depend center to center. But if you if someone would ask me, I would prefer to do PDA stent over BT shunt because what we can see is that BT shunt they do have lots of issues with over shunting and then prolonged stay. But having said that, as I mentioned, it depends center to center, whichever is better in terms of the outcome for each center. So which comes to the second question. This is, I'm pretty sure is quite easy based on the previous lecture. What type of surgical repair would you commit the patient to? Would you do anatomical repair or physiological repair? Maybe I shouldn't go to the poll. I'm pretty sure what's the answer. Okay, so it looks like there's a few of the respondents mentioned that they would go for physiology repair. Well, I guess sorry. Well, I mean, in this sense, I guess there's a. I think I would have I will not go again to all the lecture because I'm pretty sure it has been presented nicely while our other panelists. So I mean, because there's so many data show that the benefit of anatomical repair over physiological repair because of progressive TR, RV dysfunction, the interventricular, the ventral to ventricle interaction. So yeah, I guess I mean, most probably easy to be anatomical repair, but I guess it's also depend on your center, what the expertise that you guys have, because instead of not doing anything, I guess maybe doing something is better than nothing. So yeah, but I think in the center where the expertise is there, the resources is there, I guess it would be better for based on the current data, it should be better for anatomical repair. Cool. So what has been done for this patient is that this patient underwent initially they went for left modified VT shunt. Bear in mind this is in 2011, and then after that there was a bit of issue with the stent. There was a bit of stenosis, so they did the stenting, and finally in July 2012, the patient underwent mustard and Rastali, VSC closure and take down of VT shunt. So this is actually the latest echo after the procedure. So what you can see here is that nicely that the IVC drain into the, let me do it frame by frame because it'll be easier. Okay, I'm not sure how to do that. You can see the IVC nicely drain into the left-sided atrium before it enters into the left before it enters into the left-sided ventricle, which is the RV. And then the other thing also you can see this is part of the right atrium where you can see a lot of pulmonary vein draining into there. However, I can see that the IVC flow into the baffle to the left-sided atrium is laminar flow and it is unobstructed. So for this patient, actually, unfortunately there's a bit of tiny baffle leak. However, it is such a small thing, so it is not that significant. But the important thing is that there's no obstruction. So from here you can see this is part of the left ventricle, which is on the right side, and then it go in baffle into the LV, into the aorta, pardon me, and then it looks quite decent and doesn't look obstructed. And then based on flow, it is definitely not obstructed. So this is another nice view of looking at the pulmonary vein baffled into the right side of the atrium, where we can get this view when you do a 3-chamber view, but it needs to be tilted posteriorly. So what you can see here is that this is the left pulmonary drain, right pulmonary drain into this nice convex before it drain into the right side of the atrium without any obstruction. And then we can see here basically is the LV to AO. It is non-obstructed, and there was just a mild aortic insufficiency. And then from this view, you can see, and then the other thing is that before to mention is that there is no mitral valve regurgitation. And then from you can see that both ventricle function looks normal, good, quite good actually. And then there's hardly any, just a mild tricuspid valve regurgitation. And then this just to show the septal curvature, because as you know, sometimes in the patient with the CCTGA, at post-op after a few years, they can present a bit of elements of hypertension. Otherwise, actually, the septal curvature is quite normal to suggest that the right ventricle, which is the left side, actually is pressure is not high. And then definitely can see the radial function is normal. And then not to forget the Rastali, the conduit, is functioning nicely. There hardly any pulmonary regurgitation, and then there's a bit turbulence and the PA branches, but otherwise a good size. So currently patient is already 10-year-old, and the other thing is that bear in mind, patient has other underlying issues, which is a primary ciliary dyskinesia, and then it complicated with recurrent otitis media, and also finally some elements of hearing loss and also chronic bronchitis. However, this has been managed beautifully by the respiratory team. And also in terms of rhythm issue, there was an issue of atrial flutter after the BT shunt. However, current patient is asymptomatic, patient is not on any medication, and just the occasional junctional rhythm. And clinically, patients very well active, NYHA 1 to 2, asymptomatic, it grows between 70th to 80th percentile and saturating above 95%. So what's the learning points for this patient is that sometimes the diagnosis between the antenatal and postnatal can be antenatal can be a bit challenging, and then it depends because this echo was done in 2011. I guess the picture what they call the solution is not as good as now. Now we might be able to see a bit more, but however is that despite that, even whatever we see is that if we suspect like elements of heterotaxy, we still have to counsel the parents and the possibility of worst case diagnosis scenario. But having said, we still have to think of what are the possibility that patient might not be having this element of heterotaxy. And the management, the initial palliative management depends on center to center, because I'm talking about PDA, stenting or PT shunt depends on your expertise. Because whatever it is, the most important thing is that you have to maintain a good flow into the pulmonary artery. And then I guess for this patient, CCTGA pulmonary artery with large VSD, I think in terms of management is more slightly straightforward. I think because I mean, as you can see, the VSD huge, the LV to AO is non-obstructed, the valve looks fine, and then the aortic valve itself is not an issue. So I guess for this patient, it wouldn't be much of a challenge. Right? And then in terms of prognosis outcome, it is not always at the seams. Yes, patient has underlying PCD and arrhythmia. However, because patient was managed, nicely managed by the whole multidisciplinary team, patient has been very well and leading normal life. So I think I would leave the question at the end of the session. So I'm just sharing this a nice quote from my favorite author, Victor Hugo: "Life is a flower for which love is the honey." Thank you so much.
Thank you very much for that very interesting case and the nice presentation. I have the pleasure now to transition to the next speaker, who is Dr. Michael Friedman. He's been part of the Heart Center for a relatively long time by now, and currently an electrophysiology subspecialty fellow. So I'm looking forward to hear what he has to present. I assume it will be with an emphasis on electrophysiologic aspects in CCTGA. Thanks, Michael.
Thank you so much for the kind introduction, Dr. Haller. So I don't want to give anything away, being one of the electrophysiology fellows in the room, but I do want to talk about an interesting case at the juncture of structure and rhythm. So as always, the Poll Everywhere software is open and the link is in the chat, so please participate. It makes it more fun for us and makes it more fun for you guys as well. So I'm going to start off a little bit earlier and go into a fetal consultation for a 30-year-old woman, G3P1 with protective serology. In the first trimester, nuchal translucency was found to be a little bit wide, and an amniocentesis was done, which found the karyotype of a normal male. And in the second trimester, during the anatomy scan, there was an abnormal four-chamber view and bilateral pelviectasis. The mother was sent for a fetal echocardiogram at 21 weeks gestation, and because of the family's location, they weren't able to be seen until 28 weeks. During the fetal echo, and I'll put the caveat that I'm not a fetal echocardiographer or fetal cardiologist, but I'll do my best. Here we see an axial cut, posterior, anterior, right-sided, and left-sided. As we sweep through, you'll be able to see right off the bat that there's a bit of an unbalance to the ventricular arrangement, where first ventricle that you see, which is the more postero inferior ventricle, is quite a bit larger than the more antero superior ventricle. And when we look morphologically as the sweep continues to play through, you can actually see that inferior posterior ventricle is smooth walled in the same way that Bo was describing previously, most in keeping with a morphologic left ventricle. In this right-sided image, this is more of a three-vessel view type image. And if we pause it here, you can see fairly clearly, if this is the right and this is the left, you have your SVC, a larger pulmonary artery, and your anterior leftward aorta, which is consistent with the VA discordance picture in CCTGA and some other spectra of disease. In the end, the echo report actually reported a double inlet left ventricle with a morphologic normal left ventricle that is rightward and posterior to the hypoplastic RV with a single moderate unrestricted VSD, a small straddling left-sided AV valve with good-sized right AV valve with no valvar pathology, and VA discordance with an anterior leftward aorta from the RV with a hypoplastic aortic arch and antegrade flow, suggestive of possible coarctation. The rate and the rhythm were normal at that time. And the family was counseled that this is a severe form of congenital heart disease that would likely need to progress down a single ventricle palliation because of the straddling valve. And the details of the 3 stages of the Fontan palliation were discussed, including the long-term complications and life expectancies. And as always, the options were discussed, including termination, comfort measures at birth, surgical palliation. The family requested time to consider, but were most likely to move forward with surgical palliation. So the group decided to create the plan and put everything in place that the mother would need to deliver at a tertiary care hospital with prompt access to sick kids for urgent assessment and management, prostaglandins to be started immediately at delivery, given the duct-dependent systemic circulation, and transfer to the cardiac critical care unit shortly after birth. They planned to follow up at 35 weeks gestation for a repeat consultation and echocardiogram, and the pregnancy progressed very well in that time. At 36 weeks, the mother showed up, and just showing a couple of quick pictures, you can see that although the function of this morphologic left ventricle is quite good, you'll notice that it's far slower than it was in the past. Thus, the EP hat shows its ugly head. And you can see the atrial rhythm seems to be moving quite a bit faster. This 4-chamber view is showing that sort of more balanced picture. You can't see the RV quite as clearly, but this is where that right-sided AV valve was straddling. And most significant was when you do the M mode, cutting through the atrium and the ventricle at the same time, we see that the atrial contractions are happening independent of the ventricular contractions with a far slower ventricular rate, which is consistent with complete heart block. At this juncture, the ventricular rate was in the 80s. And there was no evidence of fetal high drops, but the counseling was, the tone of the counseling changed quite significantly, and the heart block was quite concerning in the new echocardiogram. The discussion focused on the fact that the prognosis was a bit poorer, and that it included that it was unclear if the baby would survive to delivery given the bradyarrhythmia. It was unclear if the parallel circulation could be well supported with complete heart block. The baby may require a pacemaker, but that still may not be adequate to provide sufficient cardiac output for a parallel circulation after a single ventricle stage 1 repair, and there's a high likelihood of death in the perinatal period. The family still decided to progress with everything as usual, with full interventions as planned, so they recommended for a planned cesarean section at 38 weeks with immediate transfer to the cardiac critical care unit on prostaglandins with isoproterenol available for heart rates less than 60 or hemodynamic instability with a bradyarrhythmia. And so the child was born, and as these stories often go, the kid looked great on arrival. APGARs were 7 at 1 minute and 9 at 5 minutes with heart rates in the high 80s and low 100s with a narrow complex junctional escape. The baby was started on prostaglandins and was transferred to the CCCU. Although I would love to spend more time on this than I'm going to, this is an ECG for the baby on day of life 1, and you can see complete heart block with the P waves marching through all the way across at the bottom here with no association whatsoever with a narrow complex junctional escape rhythm at around 75 beats per minute. Looking at his echocardiogram, moving slowly through it, you can see the morphologic LV quite clearly. And in the beginning of the sweep here, you can see the bifurcation of the initial vessel that's coming off of that posterior morphologic left ventricle, and it appears to be a pulmonary artery. You move forward, and there's a VSD linking the smaller right ventricular cavity on the left side to over here, fairly small aortic outflow to a reasonable but smaller sized ascending aorta. And in this right image here, we can see that pathway for the systemic circulation is really focusing on that LV to RV to aorta junction through a moderate-sized VSD that is unrestrictive. At this assessment as well, it was better to delineating that left-sided AV valve, which is the morphologic tricuspid valve, which had no straddling and was about a 50% override, or less than 50% override. And then looking at the great vessels themselves, they were almost side by side with reasonable commissural alignment, and the aortic valve was not substantially smaller than that pulmonary valve. Looking at the arch itself, because that was a concern in utero as well, you can see that the transverse arch is quite hypoplastic in the context of and presence of a large PDA that is shunting bidirectionally. And lastly, qualitatively good systolic function. So looking at the echo report, it was finally decided this was a CCTGA with the ventricles as I described, with a side-by-side great arteries, the anterior and leftward aorta relative to the pulmonary artery. The left-sided tricuspid valve overrides less than 50% with, I apologize, some minor straddle to the left ventricular side. And there's a small secundum ASD with left to right shunt. The VSD was unrestrictive with the flow through to the systemic circulation as I described, and the severely hypoplastic transverse arch with presumed coarctation. So moving forward to the first question of this presentation, what would you offer to this patient and family at the moment? Would you offer a hybrid procedure with a single chamber pacemaker, a hybrid procedure with a dual chamber pacemaker, a Norwood with a Blalock-Taussig-Thomas shunt, a Norwood with a Blalock-Taussig-Thomas shunt and single chamber pacemaker, or the Norwood BT shunt with a dual chamber epicardial pacemaker? So I'm really interested to see the very wide spread that we're seeing here in terms of the different options that people are considering for this patient. And it sort of highlights the complexity of this case in and of itself as to why it's such a challenging disease to manage. So it does appear as though the hybrid with single chamber pacemaker won out from a polling perspective. But as far as what was actually done, given the arch anatomy and the concern with the heart block, the decision was actually made to go forward with a Norwood BTT shunt. And given the adequate heart rate, the decision was made to not implant a permanent pacemaker during the initial operation due to several reasons. The first is officially he didn't meet at the time guideline-based criteria for pacemaker implantation. He appeared to have an adequate cardiac output preoperatively in the context of his large duct. Had a strong concern for possibility for pacemaker-induced dysfunction in the single ventricle physiology, and that's usually a bad prognostic marker for the palliation as a whole. And given the fact that the patient will have temporary wires, we'll actually be able to assess what his pacing needs would be post-operatively using an external temporary pacing device. So that's what was done. And he had a successful Norwood with a BTT shunt and arch reconstruction. Temporary pacing wires replaced, and he was returned to the CCCU with DDD pacing at 120 as his lower rate limit, up to 200 beats per minute as the upper rate limit. There were some issues in the initial post-operative day with hemodynamic stability and desaturations due to stenosis of the innominate artery, but he was brought back to the OR next day for plication of the posterior arch to release the innominate artery stenosis proximal to the BTT shunt. And after that, he remained stable from the plication with his chest open for several days. He remained in complete heart block, obviously, with his temporary pacemaker set to DDD. And during the intrinsic rhythm checks, he did have a pretty robust junctional escape rhythm at 80 to 110 beats per minute with minimal change in blood pressure. And the review from the electrophysiology service at the time suggested that he still didn't meet pacemaker indication as he had none of bradycardia-associated symptoms, bradycardia-associated low cardiac output, an irregular or unreliable escape rhythm, specifically a wide complex ventricular escape or a narrow complex escape with complex ventricular ectopy, meaning more than occasional monomorphic PVCs, and the intrinsic rate of less than 70 beats per minute. Since he didn't meet any of these criteria at this time, the decision was made to continue observing with a DDD pacemaker. After the chest was closed and he remained stable, they tried to see if he needed the pacing at all and if his intrinsic rhythm was sufficient to support the systemic circulation. They weaned him from DDD 120/200 to VVI 70, which is essentially a backup rate. So if his heart rate fell less than 70, the pacemaker would kick in for AV dysynchronous ventricular pacing. And he maintained his hemodynamics in this backup pacing with a junctional escape consistently in the 80s to 90s for 5 or 6 days. So as for the next question, the big thought is, what would you offer this 2-week-old infant? Would you offer them a pacemaker at this time? And if so, what kind of pacemaker would you offer? A single chamber epicardial pacing system for backup pacing, a dual chamber system set to VVI for backup pacing only, a dual chamber epicardial system set to physiologic pacing to maintain AV synchrony, or an epicardial cardiac resynchronization therapy device, keeping in mind this patient has no dysfunction. All right, very interesting. So about 1/3 of the group would say no pacemaker whatsoever. About 1/4 of the group each want the dual chamber system for some of that variability. And a little under 5% of the group are thinking about a single chamber pacemaker. So very interesting results. Thank you very much for your participation. All right, and as for what was done, let's make sure you can see everything without any hazy gray stuff at the top. So the kid was taken back to the OR and was actually given a single chamber epicardial permanent pacemaker set to a VVI backup mode. And the main concern at this point was there was a concern about the risk for pacemaker-induced dysfunction, and therefore the desire was actually to minimize pacing in this patient. Since he had several days through a fairly tumultuous course, including a period of sepsis with reasonable hemodynamic stability in his intrinsic rhythm out of the perioperative period, the plan was at that time to rely on the VVI backup rate and gave him a little bit more robust than we would typically give, with a backup rate of 120 beats per minute. That was then successively weaned over the course of the next number of months from after discharge from hospital. At about 5 months of age, prior to his pre-BCPS catheterization, a pacemaker check was done that showed intermittent loss of capture with the current ventricular lead, but no change whatsoever in clinical status. He was thriving and growing, which I think surprised quite a lot of the group. He was brought for the pre-BCPS cath, which showed favorable hemodynamics, and was then brought forward to the OR for his BCPS, an LPA plasty for persistent LPA hypoplasia, and a pacemaker generator change with lead replacement. And at that point, given the change in his size, they did upgrade him to a dual chamber epicardial system. And unfortunately, I wasn't able to find any of the conference notes about the discussion itself as to what made them change their mind and upgrade to the dual chamber system, or whether it was just planning in the context of the likelihood of need for AV synchrony in the future. At present, he's clinically well, growing and thriving with his Fontan circulation and pacemaker. The pacemaker wires are functioning well, and he is tolerating DDD pacing and is running around very cute in a way that people didn't really expect he would, given how significant the combination of heart block and single ventricle physiology can be. So as far as the learning points and the interesting things in this case, I think the main things that jumped out to me were the diagnostic challenge between double inlet ventricle with VA discordance and CCTGA and the transition point from the prenatal echo to the postnatal echo, the impact of complete heart block on single ventricle physiology and how it impacts the palliative process, both from a prognostic perspective and through the ability to tolerate parallel circulations and high cardiac output demands. And finally, identifying the right time to pace and the best strategy to use in an otherwise complex patient. So thank you very much for your time and attention. Thank you for your participation. And as always, stay safe out there.
Thank you very much, Michael. Excellent presentation. As we said before, we're going to hold all of the questions until the end to make sure that all of our presenters have an opportunity to go through their talks. And so without further delay, I'm very pleased to introduce our final presentation for this session. Dr. Katie Laceno, who is one of our stellar core cardiology fellows, is going to present our next case. Thank you.
Okay, I'm just having trouble sharing my screen. I don't have the option to share for some reason. Oh, there we go. Sorry about that.
All good. Take your time.
There we go. You know, 2 years in and you think you'd be able to do this better by now. Okay, and just to confirm, you're seeing the full screen view.
We're currently in presenter mode.
Okay, let's switch that. Okay, there we go.
Yep, you're good.
Okay, sorry about that. Okay, so thank you all for sticking around to listen to the talk, and to Dr. Seed for asking me to present this really interesting case of a complex CCTGA, and just wanting to talk about some of the dilemmas in decision making in this particular case. So I think everyone's got this by now, but here is the link for the poll everywhere question. Okay, so we're just going to start with a little bit of the background information. So this is a patient who had an early fetal diagnosis of a CCTGA, VSD, pulmonary stenosis, and tricuspid regurgitation. Of note, there was a significant family history with a sibling who had termination of pregnancy for heterotaxy, AVSD, aortic stenosis, and polysplenia. Our patient was born at term by spontaneous vaginal delivery with a weight of 3.2 kilos. She was vigorous at birth with no work of breathing or significant desaturations. That being said, there were certainly concerns that she could have a quite fragile circulation. So she was planned to be delivered at Mount Sinai and electively transferred to our CCU. She had an echo shortly after, which confirmed the prenatal diagnosis. So first, I'd just like to put out a quick disclaimer that many of these images are from the early 2000s. And the quality is not what we're used to today, but please bear with me. So this is a subcostal sweep showing mesocardia, usual atrial arrangement with the right atrium on the right and the left atrium on the left. We have AV and VA discordance with a large VSD and left arch, as well as you can see good biventricular function. You can also see as we sweep that there's this anatomic substrate for potential LVOT obstruction in the future. You can also see a small dysplastic pulmonary valve as we continue to sweep. You can see the aorta from the RV anteriorly and leftward of the pulmonary valve. So here's a nice 4-chamber view where you can see this ebstenoid malformation of the systemic tricuspid valve with tethering and displacement of the septal leaflet. With color, you can see a moderate eccentric jet of tricuspid regurgitation, as well as a large secundum ASD. So this is a nice view to show the small and dysplastic pulmonary valve that I had mentioned previously. With color, you can see there is some flow acceleration, but it's really starting at the level of the pulmonary valve with no subvalvular component at this time. And again, here you can see the VSD with bidirectional shunting. And so finally, for this particular echo, we've got our nice 3-vessel view, and likely what alerted the obstetricians to the potential diagnosis of CCTGA in the first place, with your aorta anterior and leftward of your pulmonary valve. So just continuing on here with the history, during her admission, she was noted to be dysmorphic with clinidactyly, redundant nuchal fold, and webbed neck. And there was a duplication of chromosome 22 that was ultimately found after the genetics team was involved. Her hospital course was really otherwise unremarkable. She was observed for several days prior to her discharge at day of life 4. And at this point, she was doing quite well, feeding well orally and no concerns for respiratory distress. And she was fully saturated with what appeared to be a reasonably well-balanced circulation. Unfortunately, at 7 weeks, she presented to an outside emergency department with significant respiratory distress and urine output. She was readmitted to sick kids. She was transferred and admitted to sick kids at the time. Unfortunately, deteriorated quite rapidly, requiring intubation, ventilation, and inotropic support. Her echo at that time showed some worsening tricuspid regurgitation, but she was gradually able to be extubated and transitioned to oral heart failure medications, which she was discharged home on several weeks later. She was brought back to clinic at 10 weeks and unfortunately readmitted again due to concerns for worsening CHF with increased work of breathing, tachypnea, reduced output. So similar to what she had presented with before. And again, her echo at this time showed quite severe TR with only mild pulmonary stenosis at the time. So I think this just highlights her fragile circulation in the setting of severe systemic TR, a high QPQS with a large VSD, and only mild pulmonary stenosis. So just a couple of quick echo pictures here. So you can see this dysplastic tricuspid valve with a central coaptation defect, and with color you see the clearly significant tricuspid regurgitation. And here's the LVOT that I mentioned. So again, you do see flow acceleration with a mild gradient of only a peak of 30. So I'll pause here for the first question. So faced with this baby who's 4 kilos, she's 10 weeks old, CCTGA, VSD, mild pulmonary stenosis and severe TR with multiple admissions for decompensated CHF, what is the course of management in this scenario? So do we do medical management, go forward for some type of physiological repair by repairing the tricuspid valve, PA band as a destination therapy, PA band for future anatomic repair, or consider the transplant route? So this is an interesting finding, and I think we'll come back to this discussion certainly at the end. And I think the answers probably really reflect how we've changed our management from the early 2000s to today with respect to the early management of these patients. Oops. So ultimately, we decided to go ahead with a physiological repair. So she had a tricuspid valvuloplasty and placement of a 38mm ring. She did require 2 bypass runs for residual moderate TR, and her final TE did show persistent moderate tricuspid regurgitation. Her postoperative course was relatively unremarkable. She initially required dual chamber pacing, but quickly recovered to sinus rhythm. She subsequently developed several episodes of SVT requiring adenosine, esmolol, and propranolol. However, these were all discontinued prior to discharge home. And she was eventually discharged home on some diuretic enoxaparin with NG feeds. So this is her echo 1 year post-op, and what you can see here is, not surprisingly, the gradient through her LVOT has progressed with a peak now of 77 from 30 in the preoperative period. And here we can see that really she's had remarkable improvement in the tricuspid regurgitation. However, in the setting of this tricuspid annuloplasty, we now have a somewhat small annulus. That being said, the inflow gradient was only 5, so just mild stenosis. And again, this is just to show that our VSD is still there, still quite large with bidirectional shunting again, but shunting from the systemic to pulmonary circulation in systole. And again, importantly, we can see that she's got preserved biventricular function. So just briefly, in terms of her clinical course throughout childhood, she did initially struggle with some failure to thrive, but picked up her weight gain after that. And she was really generally well, enjoying school, had support with an IEP. She was active in dance and gymnastics, although both she and her parents felt she could not always keep up with her peers, but was otherwise asymptomatic from a cardiovascular perspective, and her baseline saturations remained stable in the low 90s. As part of her routine follow-up, she had treadmill testing, which around the age of 8 began to show desaturations into the high 80s, mid 70s with exercise testing. And so in light of this, she underwent a complex multimodality assessment to assist with future decision-making. So she had a CMR that we're showing some images of here. And what we found was that she had a normal right ventricular size with mild hypertrophy and a preserved ejection fraction of 58%. The LV was dilated, but again, had a preserved function with an ejection fraction of 62%. And importantly, she did have a rather large QPQS at 2.7 to 1. The one thing that I really just wanted to highlight in the cine images is when you look at the LV and the aorta, there's quite a long distance between there. And when considering potential for future repairs, in particular an anatomic repair with a Rastelli, you can certainly see that there's a potential for any baffle from the LV to the aorta to obstruct this tricuspid valve and compromising the size of the left ventricular cavity. So certainly something we have to take into consideration for operative planning. So she also underwent diagnostic catheterization. So on the left of the screen, you can see a retrograde injection into the morphologically right ventricle with an unobstructed connection to the left-sided arch. In the right image, we can see the injection to the morphologically left ventricle with multi-level obstruction along the left ventricular outflow tract. In terms of the hemodynamics, the RV EDP was 7 with an RVSP of 74. LV EDP was 9 with an LVSP of 77. So again, showing that, as we could see in the echo images, the VSD was unrestrictive. There was no gradient through the RVOT. And unfortunately, we were unable to pass a wire through the pulmonary valve. So we're not able to get a pullback gradient through the LVOT. And then I think importantly, despite a long-standing elevated QPQS, her PVRI remained low at 0.74 Wood units per meter square. So now that we have all this data, she is presented in our surgical conference. What management options do you offer the family? Do you opt for some form of anatomical repair? Do you continue down the physiological route, leaving the RV as the systemic ventricle? Do you go ahead with expectant management or consider transplantation? So again, I think the answers coming in also reflect a lot of the discussion points that we had as a group. But let's just say that the group has decided to proceed with an anatomical repair. So now we need to consider which kind of anatomical repair is the most appropriate. So do we offer the family something like an atrial switch in Rastelli, an atrial switch in Nikaido? Do we consider a 1.5 ventricle repair with a hemi-mustard Senning, Rastelli, and BCPS, or do we consider a 1.5 ventricle repair with a hemi-mustard or Senning, Nikaido, and BCPS? Okay, so it looks like most people want full anatomical repair with an atrial switch and Nikaido. Very few want the 1.5 ventricle with the Nikaido or the Rastelli. So I just wanted to take a little bit of time to talk about what came up in our discussions at conference. To say that the decisions were highly variable would probably be a bit of an understatement, but she was actually discussed several times, and one of the outcomes was that we would plan for a switch, atrial switch with Rastelli if possible versus a physiological repair plus or minus a BCPS. In one discussion, the conclusion was to offer an atrial switch Nikaido or an atrial switch Rastelli. There was another discussion about a single ventricle palliation with oversewing of the tricuspid valve and a BCPS, and also discussion of a long-term plan for transplantation. So I just wanted to kind of take a minute to stop here and just recognize that there was very highly variable kind of discussions and thoughts on this matter. So we had multiple discussions regarding the possibility of both an anatomic and physiological repair, but within our group, there was really more interest in an anatomic repair. So either an atrial switch Rastelli or Nikaido, and less interest in continuing down the physiological route. So with respect to the physiological repair, so something like a VSD closure, LV to PA conduit, the concerns were largely related to the need for tricuspid valve replacement in a relatively small annulus and the need for ongoing anticoagulation. With the anatomic repair, there were concerns regarding the feasibility of the Rastelli, as I mentioned earlier, given that the left ventricle to aortic baffle would need to be quite long. And again, there's the potential for tricuspid valve inflow obstruction and compromising the size of the right ventricle. And so in light of this, the option of a Nikaido was brought up. However, with the Nikaido, you're certainly dealing with a probably more complex surgery and potential need for mobilization of the coronary arteries. Additionally, there were some concerns that given her tricuspid stenosis, she may have insufficient pulmonary flow and could perhaps need a 1.5 ventricle repair with the options I mentioned before. So something like a hemi-mustard setting, Rastelli, Nikaido, plus BCPS. So either way, I think everyone would agree that these are quite big operations and carry increasing risks of morbidity and mortality. And so really here, I just wanted to emphasize that despite numerous multidisciplinary conferences with lots of really good data, there was a really broad range of proposed management options and no real consensus with the best path forward for this patient. And ultimately, after long discussions between our group and the family, the decision from the family really was to proceed with expectant management, which I think we all felt was relatively reasonable at that time. So just really briefly, in terms of follow-up through her adolescence, saturations remained in the low 90s, and she was overall generally well. She was active in dancing and did admit to some exercise intolerance, which she felt was stable. She had no other cardiovascular symptoms. Her formal exercise testing, however, did show that her tolerance was progressively deteriorating with peak workloads, peak VO2s, and VO2 at anaerobic threshold, approximately 40% predicted for normal. And this is her most recent follow-up at 17 years. So again, she remains overall well with modest cyanosis. She continues to dance regularly, however, does endorse worsening exercise capacity and needing to take breaks much more often than her peers. And otherwise, she's also accepted a position in a local college for a social work program. Just very briefly in the echoes below, just to point out that really her LVOT gradient has remained relatively stable with a peak of 89. The inflow gradient across the tricuspid valve has increased somewhat and is now in the moderate range at 7, but she continues to have a preserved biventricular systolic function. So just some brief thoughts to summarize. So this is a case of a complex CCTGA with VSD, pulmonary stenosis, and ebstenoid tricuspid valve with severe TR, who presented with early heart failure in the setting of a very fragile and tenuous physiology, given her high QPQS with mild pulmonary stenosis and severe systemic TR. Our initial approach was to manage her with a physiological repair strategy, and therefore, to date, her only intervention has been the tricuspid repair in infancy. And while this approach was effective in addressing her heart failure at the time, she was left with a systemic right ventricle and now progressive tricuspid stenosis. Despite this, though, she has preserved biventricular function and continues to maintain a good quality of life. She's now transitioned from our program to her friends across the street in the ACHD clinic at Toronto Gen. But I think the kind of thoughts from our group really were that despite her somewhat remarkable stability in the past, given that her exercise capacity continues to decline and she appears to be becoming more symptomatic, the balance is likely shifting towards needing to intervene in the not too distant future. And so one final question, knowing what we know today, so both with respect to the patient's course and with respect to management of CCTGA in general, would our initial approach be the same? And I suspect I know the answer, but hopefully it'll bring up some good discussions. Interesting. I did not actually expect that outcome. So perhaps we can talk a little bit about that. I think we've got time for discussion now, but that's it for me. Thank you so much for your attention.
Thank you so much to all of our three presenters. I think really the cases all highlight the high degree of complexity in these cases. And I think I'm going to take the opportunity. There is one question in the Q&A that I think really gets to what is a broader question, which Katie, you were kind of getting at this at the end. So I think I'd like to open up for discussion around, you asked, would we do the same thing today that was done in these cases? I think that gets to, if you look at all of the audience polling, what was done actually was never the number one choice that the audience had for today. And so I'd be curious for our trainees first, and then we can open up to others. Do you think this is a center effect? Is it based off of different center preferences? Is it based off of the era effect that we're just further down the road and we know better? And we think we do it differently? That's kind of a bit of what Katie was getting at. Or do you think the other possibility would be, are there patient-related factors or family-related factors that you can't capture in the chart review? So I'd love to hear our speakers' thoughts on that and the influence of those three different potential things.
I mean, I can comment a little bit to the patient that I presented. I do think, obviously I wasn't there, but from what I was able to gather from the charts, I'm not so clear on the early piece, but certainly towards the discussions as she was a child and into adolescence, there was a big, the family had a big kind of contribution. They had strong feelings. The patient had really strong feelings that she was having a good quality of life, and the risk of such a big operation was probably not worth it for them. So, which, I think is quite reasonable in this case. But yeah, not quite answering the question you posed in the first place, but at least with this family, I know that they had they certainly had strong feelings on how they wanted to proceed.
And when I signed up for this, I certainly didn't expect to be asked such a challenging question. But quite opposite from Kate's family, who had very strong opinions. The family in the case that I was presenting actually was very keen on whatever the doctors decided is what we will do. So it really emphasized the importance and the magnitude of the decisions that we're making, because in the context of a complex single ventricle physiology, the decision to start off with pacing at a young age when they don't necessarily need it, and the complications associated with a device that happen really early in life, and the challenges with a complex ventricular anatomy, finding the right place to put the lead, dealing with pacemaker-induced dysfunction. These are not trivial things to consider. And although it always seems easy in the moment to say, oh, well, let's get AP to put a pacemaker in, it'll solve all of the problems. It's not actually as cut and dry with that. And looking at the complex, as you said, Dr. Moga, interplays between the social dynamics with the family, what the family is capable of dealing with and handling, because this patient also happened to live quite remote from urgent medical access. So there are lots of very complex factors that filter in. And I agree with you completely that a chart review and the hours put into trying to put a presentation like this together are completely insufficient compared to the longitudinal relationships that centers develop with their patients to really understand why these decisions should be made for each of these individuals. And keeping that in mind, I think, is of the utmost importance, that these are individuals and the data say certain things, but the data are not the individual sitting in front of you.
Thank you, Mike. I think from my point of view, because I'm from a different sets of mind, I think I would, the one thing that I would agree with you is that in terms of family dynamics that you mentioned, but because if you want to do a bit more complexity and complex surgical repair, and then where you need, when you have a patient so they live in remote, like in Malaysia, sometimes the only way you can come is by helicopter, sometimes, so it can be a bit difficult. So sometimes what we do is that we would even though if patient is good for single ventricle, but if the patient wouldn't be able to come for a follow-up, we would just do as expected management sometimes. But I guess in terms of managing patient, I mean, I personally, if I would do the Hemi sending plus Nikaido, looking at the LVOT and then the structural issues of the RV. But having said that, it also depends on center, but because I mean, it depends on the center. If the center has a good outcome on Nikaido, well, I think maybe go ahead. But the parents and the patient, parent has to really understand what are the possibility that's what's the outcome. It means that we have to tell them from the very beginning that this is what we're going to do, and then these are the possibility that patient might be having. It might be bleak outcome, or it can be a nice outcome before, because sometimes it depends also on the social background. If they are the type that they're always half glass full, it can be a bit difficult. That everything is positive. I mean, we have to paint the picture that no, it's not half glass full. It can be half glass full, half glass empty. So yes, that's what you say. It depends at the center, and depend on the expertise of your center. Yeah, I think that's my opinion from my minimal experience in handling this.
Excellent. Well, we would like to thank all three of you. Really a fascinating discussion. And I think we have time for one last question, and then I will wrap up.
David, your hand is up.
Hi, no, thank you. I want to say thank you to all three presenters, because they were excellent presentations and very interesting cases. But I think, just to go back to the last one, which again emphasizes how, despite all we've learned or think we've learned, it's still really difficult making the right decision. But I think the message I take is that actually the combination of VSD with just the right amount of left outflow tract obstruction can be a very stable circulation, and the case in fact goes to show that. And the trouble is the tricuspid valve regurgitation is so unpredictable, and you don't know what's going to happen once you try and manage the tricuspid regurgitation. But as you saw in this case, actually you then ended up with a very stable circulation. I think looking at the intracardiac anatomy, an Hokkaido would be really quite a challenge. It is a remote VSD, and the Hokkaido would be quite a brutal operation, I think, trying to move the whole outflow tracts across. And I just wonder, in that situation where you've actually still got really good systemic RV function, you'd be better off with, if you were forced into anything, just with a physiological repair with a VSD closure, and probably leaving them deliberately limiting LVPA conduit to deliberately keep the pressure up in the in the subpulmonary ventricle.
Thank you so much. Really a great session, everyone, and lots of food for thought. I'd like to say that with these kinds of cardiologists coming up the pipeline, the future is bright indeed. Excellent job, everyone. And so we have a short break now. We've run over a little bit, so about 5 minutes, and then we're back on to wrap up the meeting. Thanks very much, everyone.
Hello, everyone, and welcome back from the break. It's my pleasure to introduce our next session, which is Big Questions in CCTGA, Proposed Treatment Algorithm. Our speaker is Dr. David Barron, and it's my pleasure to introduce him. He's the Division Head of Cardiovascular Surgery at the Hospital for Sick Children. David came to us in Canada in June of 2019, having been the Senior Cardiac Surgeon at Birmingham Children's Hospital in the UK since 1999. David is also the director of the Adult Congenital Heart Surgery Program at UHN, and he leads the team of 4 specialized cardiac surgeons who deliver the largest ACHD service in Canada. He graduated from St. Thomas's Hospital in London, UK, and had his cardiothoracic training at Papworth Hospital, Southampton, the Royal Brompton Hospital, and Great Ormond Street, London. He is a professor at surgery at the University of Toronto. And it's been excellent having you as a colleague, David. I look forward to hearing your talk.
Thanks, Roxanne. Let me just share my slides. Well, thank you. And it's been a very interesting couple of days. And I think it's just emphasized how difficult it is, the decision making in some of these patients. I'm just going to try and synthesize what I've learned, what I hope we've all learned over the last couple of days, and perhaps just try and work towards kind of what we imagine as being some treatment algorithms. And I think bearing in mind that we've seen how how variable all these patients are as to why the decision making can be so difficult, and that why obviously sometimes you have to make an individualized decision. So they're very variable. This is, I think I just put this slide out there to remind us just what a wide range of lesions there are, and that we have to remember that although sometimes we think of CCTGA as simple CCTGA with no VSD and no other associated cardiac lesions, we must remember that 85% of the patients will have some sort of associated lesion, and they're a whole mixture. But it's because of this that you can't just pigeonhole it into a sort of discrete group and say there's a single sort of decision algorithm for every patient. The heart's in different positions. You have different degrees of tricuspid abnormalities and regurgitation. 70 to 80% of the patients are going to have a VSD of variable size, but you also get problems with the arch. You get these very Epstein-like tricuspid valves that can be very leaky in the systemic circulation. And on top of it all, you get the problems with heart block. And even in the patients who have no associated lesions, the performance of the right ventricle in the systemic circulation is incredibly unpredictable. So you have some patients, as we have heard, who will live into their 80s and 90s without ever needing anything doing, others who will be in heart failure even within the first year of life. So that's why it's so difficult, and that's why we have to design sort of management protocols based on the different situations we may be faced with. And these are typically the sort of comments that we hear, and there may be truth in all of them. But these are the things we're trying to debunk to some extent and give ourselves a really more objective way of managing the problem. Certainly we see patients who have no associated lesions who can remain very well, and it's trying to pick exactly which those patients are, which is of course the magic bullet that we need. And we know that double switch and the anatomical repairs are pretty formidable procedures, but also we've seen that the outcomes can be dramatically better than the natural history in the right patient. So just to remind you, perhaps again to go back over some of the data that we've heard over the last 2 days, and I think that there's no apology for going back over some of this material. We have to remember that this is the natural history for the majority of patients with CCTGA. On the whole, it's a pretty malignant condition to live with. This has repeatedly been shown, this graphic really from a multi-institutional study of adults with CCTGA. So you had to be an adult to even have arrived in this cohort. So this is already the best patients with CCTGA. It's those that have survived through childhood to be an age of 18 before they enter into these survival curves. And you can see that even then, the perfect CCTGAs that had no ventricular dysfunction have by no means a normal life expectancy. So it just reminds us that it's not an easy or safe condition to watch, and we have to keep our guard up at all times. And also this quite well-known study from Jane Somerville way back in 1990 that was called The Natural and Unnatural History of Congenitally Corrected Transposition, because it really took a snapshot of their entire experience in their outpatient department at the Brompton with CCTGA patients before the era of the double switch, and it identified that yes, there were some patients who had good function and no tricuspid regurgitation who did very well, but all those who had tricuspid regurgitation or a VSD or any sort of associated lesion, you can see immediately had a really quite dramatically poor survival, and that this group were 10% of the whole patient cohort. 90% of the patients fall into this other cohort. And if you combine these sorts of papers, what we've learned about the sort of natural history of CCTGA, well, less than a half of these patients would survive into adulthood. And even the best patients, those who do survive sort of unscathed into adulthood, well, 50% of those patients will be in heart failure within 20 years. So we have to always bear that in mind when we think about how to manage this really difficult condition. This is the Boston data, again, which emphasizes, this is now current contemporary data, emphasizing how difficult or how unpredictable the performance of the ventricle, the systemic ventricles and CCTGA. So look at these, this is freedom from significant complications. So that's death, transplant, or severe systemic ventricular dysfunction. And you can see again in this large cohort in the current era from Boston that as soon as you've got any sort of right ventricular dysfunction, your prospects are severely limited. So it is important that we do devise the best management plans at an early age for these patients to try and influence these survival curves or the natural history of the condition. What about conventional repair or physiological repair? Well, I think you just have to look at some of these studies that again are relatively recent. So this isn't that historical data, but these are the outcomes of conventional repair. And again, if you look at both the survivals and the freedom from subsequent right ventricular dysfunction, it's slightly worse than the natural history that we've just looked at. So the outcomes of physiological repair on the whole are very disappointing. And I think there is still, without doubt, a group of patients for whom physiological repair is still the right thing to do. But you have to have good tricuspid valve function. You have to have well-sustained systemic right ventricular function to really get a good outcome from physiological repair. So you have to be very careful that you choose the patients wisely if you're going to go down this route. And when you then start to look at some of the published outcomes of anatomical repair, and you put these in the context of the natural history or the outcomes of physiological repair, you can see that they're dramatically different to the natural history of the disease. So I do think there is good evidence that anatomical repair really does offer a better survival and better outcomes for these patients, for the ones who are heading down that curve of the natural history where they've got some systemic ventricular dysfunction or they've got tricuspid valve dysfunction. And the outcomes of anatomical repair, bearing in mind the majority of these patients are those that are already in trouble. So they're already in the bad end of the spectrum, looking down the barrel at a bad prognosis. And it really does transform the prognosis for that group of patients. That's the Boston data that Ramamani was telling us about, equally, very encouraging outcomes for anatomical repair when you're careful about your patient selection. And often one of the criticisms I think thrown at the data is that there's no real contemporary population comparison. We're looking at old historical data, but the Boston studies that Ramamani explained to us so beautifully yesterday really did look at contemporary management by the same center, managing the same groups of patients, some of whom they managed conservatively or with physiological repair, and some of whom they managed with anatomical repair. And there's no doubt that in age-matched groups, the risk of death, transplant, or severe ventricular dysfunction was 5 times less with anatomical repair than it was with physiological repair or any sort of management that left the right ventricle as the systemic ventricle. So anatomical repair isn't perfect, and there are still some patients who do get a ventricular dysfunction post-op. But if you look objectively at the outcomes comparing the two groups, anatomical repair does seem to give you a survival benefit and a benefit in terms of freedom from ventricular dysfunction. It's even more striking when you look not only at the age-matched groups, but at the entire cohorts from that Boston series. And you can again see the potential survival benefit of the double switch. But what we've also learned is the downside of the double switch is that reintervention rates are high, and that there is a small but important risk of left ventricular dysfunction following anatomical repair. Those are typical sort of outcomes for reintervention rates, probably sort of 30% at 20 years. And again, this was some studies, some of our studies from Birmingham before I came here, where again we highlighted that it's the retrained ventricles that are the ones that are at risk, perhaps of later dysfunction. And the Boston study again showed that if you're able to do the banding early, the double switch relatively early, you're less likely to get late ventricular dysfunction. And again, perhaps this is just a little note. One of the worries about one of the late sequelae of double switch is the risk of aortic regurgitation, neo-aortic regurgitation, and that being a bit more aware of that when you actually perform the double switch, and maybe this sort of approach where you actually do an annuloplasty on the aortic root if it's dilated at the time of the double switch, might reduce the risk of aortic valve dysfunction later in life. But one of the biggest questions that we've tried to sort of grapple with over the last 2 days is, how old is too old to attempt to retrain a ventricle, and how, when is the double switch no longer worth it? Is there an age at which the risk of trying to retrain the ventricle is too high? Is it 5 years of age? Is it 10 years of age? Is it 15? I think those are the things that even now we're still not quite sure what the right answer is. And to try and answer it, I just have taken a slight sort of diversion to look at what we learned from the old days when we did the atrial switch, the regular transposition, and we went through a period in the sort of 1990s where we had a population of relatively young patients who were post-senning or mustard, the regular transposition, where there was an option to reverse the mustard and perform an arterial switch. But to do so, you had to retrain the ventricle. And this is kind of where a lot of our evidence came from retraining ventricles. And of course, these were a relatively older population than the population we've been talking about over the last 2 days in the setting of CCTGA. And what did we learn? So Melbourne, Roger Mee in Melbourne and Cleveland Clinic combines his experience, and his sort of publications with the widest experience with these patients who are relatively older, and you attempt to retrain the ventricle. So what was interesting is a mean age here of 11.4 years You know, quite a high mortality, and a third of the patients just didn't respond to banding. So that's a really important message. That there are a few other slightly smaller studies. If you combine all the patients from all these sort of studies that were published of trying to retrain ventricles in slightly older patients, you found that half the patients who were around the sort of age of 12 years would not retrain. So it's clear that around this sort of age is probably the limit of what can be achieved. And if you look at all of the data, you see that the oldest patient who was successfully switched was 16 years of age. And that if you look at all the patients who were 12 years or older, only 20% of cases could be successfully trained. And that was despite the fact that you could still see a change in LV mass. But to get a really good response from a band once you're 12 years or older was really unlikely. So I think that the message we tend to take from that is that really around the age of 10, 12 years probably is the absolute limit for when we should be attempting to retrain ventricles with an eye to an anatomical repair. Stanford have had a little bit more success than many groups, and it brings us to the thing that Andrew Reddington was talking about in terms of perhaps we need to be a little bit smarter about the way we retrain ventricles. But certainly the Stanford sort of publications show that in a relatively small number of patients, they did manage to get quite a lot of those ventricles to train. But even so, they still had one of those 5 patients developed ventricular dysfunction post-op. So again, really, as I say, once you're out for sort of 12, 15 years, it's very unusual to successfully be able to retrain ventricles. So trying to, go back to thinking of sort of treatment algorithms. This is perhaps a sort of way of designing an algorithm for how to retrain ventricles. And again, in mind of what Andrew Reddington was telling us yesterday, I think, the use of pressure volume loops are being underused in terms of really understanding the subtleties of what we're trying to do to these ventricles. We're doing something pretty non-physiological to put this afterload stress on a ventricle, and we have to do it very carefully, and you want to probably try and do it incrementally. But we probably need to try and achieve a ventricle that then subsequently reaches 80% systemic at least, if we're going to then be able to do a double switch. And we'd like to see that come up to 100% with a bit of inotropic support. And it should do so without a rise in the end diastolic pressure. We want to see close to normal LV mass in these ventricles that we've trained, and we certainly want to see normal function. This little table at the bottom here was the Stanford experience when they looked in retrospect at their patients who'd either done well after double switch or done badly after double switch. And you can see that those that had sustained good ventricular function were those that had a very good band gradient preoperatively, had responded very well to the band before they had their double switch, whereas those who did badly did not respond so well to the band. So the way that the ventricle responds to banding and retraining is a very important indicator of how they're likely to then subsequently perform the double switch. And this is really the same data, just pointing out that those who do well after their double switch are the ones that respond really well to the band. So this would be the sort of things that I think is the right way to approach banding. You obviously look very carefully at function. You then take them to the cath lab. You look at pressures across the band. You want to see at least 80% LV pressure. And then you want to do something like give inotrope, or even do this where you put a little balloon across the band to deliberately sort of tighten the band in the cath lab. And you want to see that ventricular pressure come up from 80% to 100% with no change in the end diastolic pressure. That tells you that you've got a really well-trained left ventricle, and it's going to be a good candidate for a double switch. So I think in terms of, say, sort of treatment algorithms, then this is the sort of thing we should be looking at. Here are your patients who you hopefully have banded successfully, or you've banded and you're now going to assess them for a potential double switch. on the left side of the screen here, as long as you've got a good pressure, maybe even as high as 90% systemic at rest, a normal LV mass, a normal function, pressures that come up easily to 100% systemic when you get into butamine, then they should be really good candidates for double switch and have excellent long-term outcomes. On the other end of this treatment algorithm are those patients. These are often the older patients who you're trying to retrain with a band, and despite banding them, you can't get the systemic pressure to respond to the band, even to the point that you start to see impaired function of that left ventricle, despite the fact it's not generating a high pressure. And these are the patients that are simply not going to respond to banding and are probably best managed with medical heart failure treatment and with a transplant pathway. It's these patients in the middle which are going to be obviously more challenging. If they're nearly there and they've got pressure of 75 to 80%, you can do things to maybe really see if you can push the strain on the ventricle and see if you can get that pressure up to 100% with no change in the end-diastolic pressure. So even these patients may be suitable, go straight through for a double switch. But if they're not quite there, then maybe we should create an ASD and then give them time, restudy them, and then they may become patients who are then suitable for double switch. And even rebanding plus or minus an ASD will be the right thing to do. There's certainly many people's experience are they're not necessary to give up after one banding, and even 2 or 3 bandings, as long as the LV function is well sustained, may still get you to the point of a successful double switch with good long-term outcomes. So what else did we learn? So very interesting to hear the Paris experience. A lot of people are talking about it. It's pretty aggressive. And I think most people feel slightly uncomfortable with the idea of prophylactic banding. And for sure, I think perhaps their experience has justified those concerns because they've not been able to show that banding prophylactically is with zero risk. It's low risk, but it's not zero. But certainly, when you look at some of their outcomes, all their patients have sustained left ventricular function. So from the purely the point of view of looking at left ventricular function compared to the natural history of CCTGA, this would seem to have at least some merit in sustaining left ventricular function, and meaning that all these patients are potentially good candidates for a double switch should they come to need it. But it's this big question mark over the fact that it's not at zero risk. And so is it valid to take that risk of these patients? And I think even the Paris group, I feel a little bit uncomfortable about offering a prophylactic band in patients who really got completely normal right ventricular function and they've got no tricuspid regurgitation. I think as soon as you've got a sniff of ventricular dysfunction or some tricuspid regurgitation, then I think you've got a mandate to offer a band. I think if you are an institution that is that supports the concept of anatomical repair, then I think there's good evidence to say that as soon as you've got some tricuspid regurgitation or ventricular dysfunction, there is an argument to offer banding very early, because the earlier you band, the better chance you have of a good long-term outcome with a double switch. But for sure, this is an area that's still going to be controversial for years to come. There is, on top of that, some very good evidence that, again, banding early may be, a definitive treatment for many of these patients. And if you can put bands on that can be safely dilated sequentially, like in the way that Olivier was describing, then you may get sustained, preservation of systemic ventricular function in these patients with an early band. But I think if you band them too late, you may not ever gain that benefit. I'm going to finish off with perhaps some suggested algorithms from what we've learned, and perhaps what our philosophy has become here at Sick Kids. how to manage these patients. So firstly, those patients who perhaps are the most challenging, those who've got no associated lesions, no VSD, and no abnormal valvar function, normal aortic arch, and so forth. And of course, the first thing I think to say is if they've got good RV function and no tricuspid regurgitation, then these patients probably should simply be watched and have no intervention, because some of these patients will be those that never come to need any intervention and may lead a healthy life without ever developing dysfunction, but always have in the back of your mind those natural survival curves. And remember that most of these patients will not be so lucky and they will run into trouble. So they need careful observation and follow-up. The flip side to that is those patients who've got tricuspid regurgitation or right ventricular dysfunction. And these patients are all going to run into trouble. And then probably, who knows the right number, the right age. If you're under 10 years of age, I think certainly the option of banding with a view to retraining and the subsequent double switch would still be our aim. If you're older than 10 years, then probably you're reaching the point where retraining isn't going to be successful. But that's not to say that a pulmonary artery band may still have some therapeutic benefit, even if you never intend to take them through a double switch. But probably early tricuspid valve replacement will be beneficial in those patients. There'll be some patients who just fail banding and they don't respond to the band. And again, these patients are going to need to be that group who may end up going down transplant assessment pathway. But very important that even these patients who seem to at least have sustained good ventricular function, you have to keep them under review, because if they do start to develop ventricular dysfunction or tricuspid regurgitation, there may still be an option, if they're young enough, to consider an anatomic repair if that's the way they're heading. The next group of patients are those who have got associated lesions. Commonest, of course, is a VSD. And I think most of us would agree that the first step with a patient with a VSD is that they get a pulmonary artery band, and that particularly if you're a centre that supports anatomic repair, the intention of a band is really with a view to a subsequent double switch with VSD closure. It's not exclusive, and I think, once if you've had the band and you have genuinely well-preserved normal systemic ventricular function, no tricuspid regurgitation, and there's certainly an argument for physiological repair in that group of patients. But I think most of us, if you've got a VSD, so you're committed to some sort of intracardiac operation, then you'll probably in most patients go down the view of taking them through an anatomical repair. But the other group of patients are those with the combination of a VSD and pulmonary stenosis, or LVOTO of some description. And those patients can, if they're lucky, be very well balanced and not require any intervention, a little like one of those cases that we just presented. Often these patients do not have tricuspid regurgitation, and the combination of the VSD and subpulmonary or pulmonary stenosis is an extremely well-balanced circulation. But of course, they may start to become increasingly cyanosed, particularly on exercise, so they may start to become needing of some sort of intervention. Those patients who are really blue, or those with pulmonary atresia, will need usually a Blaylock shunt or a PDA stent as a first intervention, and are most likely to end up down the route of a Rastelli stenting. And on the whole, the outcomes for Rastelli stenting or Rastelli mustard are very good, because the morphologic left ventricle, by definition, has always been sustained at a high ventricular pressure, and there's less risk of ventricular dysfunction. So achieving anatomical repair in many of these patients can be very successful. But yet again, there are some patients, particularly those with remote VSD, where if the ventricular function's good, there's an option for physiological repair in these patients if you choose the patients correctly. And again, in those patients where they've really got well-sustained systemic ventricular function and no tricuspid regurgitation, this may be a reasonable route. you probably want to deliberately give them an undersized LVPA conduit so that you sustain their subpulmonary ventricle at high pressure to splint the ventricular septum and help support the systemic right ventricle. And what about the adult with CCTGA? So these, again, really challenging group of patients. Heidi Connolly from Mayo gave us a lovely presentation. Sami just spoke to us about the surgical options. So this group of patients can again be very difficult in decision making. By definition, the adults have made it through. They're usually a self-selected group. So they're generally, when we're talking about the adults, they're patients who've got intact septum and have survived and have remained well throughout childhood. But remember again, those natural history curves I showed at the beginning. And again, these patients are not free from developing problems as the years go by. And a lot of them are going to develop ventricular dysfunction and tricuspid valve dysfunction over their, sort of early adult life. Mixed in amongst this are all the patients who've had either physiological repairs or anatomical repairs in childhood, who are going to present to us in the ACHD clinics with some of the sequelae that we've just been talking about from either their physiologic or their anatomical repairs. But I think amongst these adults, the right time to intervene is still really difficult to know. Do we repair or replace the tricuspid valve if they've got regurgitation? I think the role of resynchronization therapy has perhaps been underplayed and can have a dramatic benefit in a lot of these patients. And there's also, the role of the pulmonary artery band, not in any way trying to retrain ventricles in this age group, but in its benefit in splinting the septum, we still don't really understand. But I think just to remind you of this Mayo data, which was shown several times, it just reminds us that if you've got moderate or more tricuspid regurgitation in an adult, then if you can operate before the ejection fraction deteriorates, the outcome is dramatically improved in these patients. So there's a strong argument for offering tricuspid valve replacement even in asymptomatic adults, even if they've still got well-sustained ventricular function. So replacement rather than repair seems to be much more reliable, but being prepared to offer replacement over just watching these patients, if they've still got good function, may really be in the benefit of a lot of these adult patients and protect them from developing so much failure later in their middle age. Now, Heidi showed this picture. I've just sort of adapted it slightly from Christian Brizard in Melbourne, showed this last year, and I don't want to go into the details too much, but again, one way of looking at the adults is to say those that have got a VSD with PS, which are the balanced patients, and the balanced patients generally will do very well, and actually very few of them will need much doing. But the commonest group, if you focus on the left-hand side of the screen, the commonest groups are those with intact ventricular septum who've made it through childhood without needing intervention. And I think intervention is based a lot on their tricuspid valve function. If they've got significant tricuspid regurgitation with a good ventricular function, then they may well benefit from tricuspid valve replacement. If they've got poor function, then they may well already be really heading down a route of either medical treatment or transplant assessment. Because once you've developed impaired function, they're very difficult to influence that in the adults. So to finish off, is the double switch worth it? I think in children, if you've got no tricuspid regurgitation and you've got good function, then it's just not necessary. You do nothing, because these may be at 5% of all CCTGA who are actually going to do extremely well. We wish we knew how we can identify this group. Trouble is, we can't predict which of our patients are going to be in this group and which are going to be the ones who run into trouble. We have to remember that that is the majority of patients who will develop trouble. So I think if you have any symptoms, if you have developed some tricuspid regurgitation, or starting to develop RV dysfunction, then I think there's clear evidence that the double switch or the anatomical repair is worth it, and that relatively early and proactive management is the right way to manage these patients, because doing the banding or the retraining or doing the anatomical repair early is what gives you the best long-term outcomes. We don't always get the opportunity to operate early or to retrain these ventricles early, but probably the evidence tells us that around 10 to 12 years of age is the age limit for really being able to successfully retrain ventricles. And even out at this age, you have to be a little bit cautious. And by far the best outcomes for retraining are achieved if you're able to retrain the ventricles at a much earlier age, probably under 2 years. Although the anatomical repair, I think, has clearly shown benefits over the natural history, I think the downside are high reintervention rates, and we have to look at ways of trying to reduce the need for reintervention. And there is this small group of patients who will develop late left ventricular dysfunction, but it's still preferable, I think, to the natural history of CCTGA in the vast majority of cases. And that CRT in patients, particularly patients who develop natural heart block, CRT can also have a very important role in these patients. In the adults, I don't think there's any place really for the double switch, except in really exceptional cases where you may have VSD and subpulmonary stenosis that have sustained the left ventricle all their lives, and they're becoming more cyanotic over time, and those may be the odd case who are suitable for a Rastetti setting type operation as an adult. But the vast majority of adults, it's all about trying to maintain a good function and maintain good tricuspid valve function, which usually means tricuspid valve replacement. That's a sort of copy of just how complicated the algorithms can be to remind us it's not easy. But I just want to finish up by saying thank you to everybody. Thank you to the faculty, and thank you to all of you. We've had more than 200 people attending the conference free throughout the whole 2 days, and as many as 300 at times. So thank you, everybody. Thank you for all your contributions. And it's really been a useful, I think, and constructive way of piecing together a lot of data on this very difficult subject. And I think we are coming towards algorithms to help us manage and improve our decision-making in what are the most challenging group of patients, but those in whom some of the outcomes can be extremely rewarding. Thank you.
Thank you, David. I think we have about 10 minutes left for questions, so please feel free to put them in the Q&A. You have compliments coming in on an excellent presentation, not failing to impress and educate us to the best, and some more thanks for the symposium. If there was one, David, I think it was such a great summary, because the final slide kind of says it all as to how complicated it is. How do you sort of message this, that it's, besides saying, oh, it's really complicated, how do you sort of attune people to, how are you going to sell your algorithm so that everybody's using the same one? I think it's going to be hard to understand if your algorithm's working, if you're not all kind of operating from the same basis. Do you foresee that as a challenge, or how would you overcome that?
Yeah, it is, and I think we've learned from hearing the presentations over the last 2 days is that institutions tend to kind of have a kind of, well, it's not fair to call it a bias, but they have an institutional kind of philosophy of how to approach it. And I think it's very important to recognise that and say this is how we should all do that. So this is how we feel is the best way to manage it, because you can see that certainly outcomes are different. For the same sort of algorithms in different centers. So you have to choose what you think is going to be best in your hands. And I think, as at the basis of all these things, is learning to be very frank and honest with the patients and their families is also very helpful, because there's no shame in saying, look, this is really complicated. And we as a group of doctors don't always know the best thing to offer you, and so I think helping the families to understand that as well helps carry everybody along, and understanding that it's always not a guaranteed sort of solution both ways. But I think what is helpful is that these sorts of meetings and just the amount of data that is being accumulated is gradually helping us understand the best way to manage them. I think the Boston data is very compelling, but equally the Paris experience is quite compelling. But you can see how it can be driven, by a strong institutional philosophy. But I think it's interesting that I got the impression reading that the Boston sort of people feel they're close to offering prophylactic banding for younger children. I think if the family are on board with that and agree it's the right thing to do, I think it's probably still a step too far. And that, but I think as soon as you've got some ventricular dysfunction or tricuspid regurgitation, then you've probably got a mandate to offer a band in that situation.
Thanks, David. There's a couple of questions in the chat. I'm going to throw the first one to you. How will you deal with an infant who has a bad tricuspid valve right from the beginning and a PA band isn't going to fix it?
I think it's true that the particular kind of the patients with a really deformed or Epstein-like tricuspid valve, a band will not stop that valve from leaking. But you still put a band on, because what you want is to get them ready for a double switch as soon as possible. And I have done some neonatal double switches in those sorts of situations when the patient is in just kind of severe congestive cardiac failure because their systemic valve, their tricuspid valve, is so bad and failing. So of course the benefit of it in a neonate is that the subpulmonary ventricle is still at systemic pressure. So you can go straight to a double switch. No one would like to as a neonate, but it can be done. And ideally, you will band them to sustain that LV, their morphologic LV at systemic pressure, and plan for a double switch probably very early in life, in the first 6 months of life. But it can be done. And that's how you manage badly leaking tricuspid valve, I think, in a newborn.
Thanks, David. Leading us into the double switch, I think this question ties in nicely. So first was, thanks for an excellent presentation and conference. The question is, any suggestions for undertaking an anatomic repair in the setting of surgeons having relatively little experience with an atrial switch? Do you think that an anatomic repair be limited to just a few centers that have the surgical experience?
Yeah, because it's intriguing how the atrial switch has kind of become redundant in most of our practice, unless you have a sort of population of patients with double switch, you hardly ever need to even think about an atrial switch. There are some ways around it. One way that's quite popular is to do a bidirectional Glenn and then to do what we call a hemi-mustard. So it makes the atrial switch much more straightforward. And I think even, if you're not comfortable with the concept of an atrial switch, you can do that approach. So you do a bidirectional Glenn, and then you only have to really think about switching over the IVC pathway. So to do that, you simply, well, nothing simple, but you cut out the atrial septum, and then you simply construct a circular baffle, a circular patch that encircles the IVC orifice and commits it across the atrial septum to the tricuspid valve, which is of course the posterior AV valve. So conceptually, surgically, that's reasonably straightforward to do. And so that's really a sort of 1.5 type repair, but it certainly makes the atrial switch relatively straightforward. So I think that's a good way around it if you're not comfortable with the atrial switch. I still would prefer the full double switch because you want the full benefit of a biventricular circulation.
So if you can get around it anatomically by altering how you do the surgery, you would do that over limiting the repair to centers maintaining atrial switch experience? I mean,
Well,
it seems
if
to me
you're
that
lucky
you
enough,
can get around it, and then
Yeah.
you might lose further experience with atrial switches. I don't know what you think.
For sure. I mean, it becomes quite a political discussion about whether you should have centres where you have centralised surgery for for certain complex conditions like this. I would strongly support that if you are working within a health system that will accommodate that sort of patient referral pattern, which isn't. You don't always have either the geographical ability to do so, or the kind of political or health service environment where you're able to do it. I would definitely, for these sorts of things, I think they should be centralised to centres that have a large experience with it. But I'm afraid we don't always all have that opportunity.
Wonderful. I think that's a nice balance of the ideal versus the realities we all have to exist in. There's another question here for you. Just asking where you're going to draw the line for the degree of Epstein's that you would take them on to a single ventricle pathway after the PA band. And I believe this is just referring back to the earlier question of what if the tricuspid doesn't work.
Well, yeah, so I'm always slightly uncomfortable with the term Epstein as it's used in the setting of CCTGA, because it's not the same as the Epstein anomaly that we see, when it's in a true, in a normally connected heart. And they're called Epstein-like, Epsteinoid, because you get the displacement of the septal leaflet, but it's not the same lesion. And the ventricular cavity is usually a completely adequate size to support a biventricular circulation. So I would very much hope not to have to take any of these patients down a sort of single ventricle type pathway if the major concern is simply the tricuspid regurgitation, and that you should be able to get them through to a biventricular circulation, through an anatomic repair, through a double switch. If you're really worried about the systemic, the systemic ventricular function in this setting, and you can do the double switch as a 1.5 type repair, and that's an extra way of protecting your subpulmonary ventricle if you think it's slightly small, because you can do the bidirectional Glenn at the same time to take the sort of volume load off the right ventricle. But you should be able to get to. I would hope you wouldn't have to end up down a single ventricle route in those patients.
Great. Thanks, David. I think we have just a couple of moments left, and I feel we've had you in the hot seat long enough. So I think we can close down this ending session, and I'm going to turn it back over to the conference organizers. Thank you for an excellent presentation and for answering all those questions, David.
Thanks, Roxanne.
Hi there. Thank you very much to everyone. My video is now working. Just wanted to finish up by doing one last poll. So I'll just share my screen and show you the code once again. If you could just log on to the poll everywhere, and we're going to do one last poll. Choose one word to describe your thoughts on this conference. Great. Thanks so much, everybody. And final thing is really to thank the people who have made this meeting possible. And that really is Steve from the IT group, the AV group, who's done a sterling effort today in showing us the in leading us through the meeting, and also to Sue Morton. Thanks so much for all her hard work, as well as her assistant Natasha Khan, who did a lot of work also in helping with behind the scenes and getting all the meeting organized. So thanks so much to both of you. We couldn't have done it without you. All right, and that's all. So thank you very much. See you next time, and good night.